Okay, Majed, we're ready for you.
Okay. Do you want to start the meeting or do you want me just to start?
Yeah, welcome everyone, and then go ahead and introduce. It's all written out there.
Okay. So, welcome everyone, and thank you for joining the BMSS annual meeting for the November 1st, 2023. So, I'm going to go ahead and introduce the first speaker, Dr. Shander. Shander is Emeritus Chair, Department of Anesthesiology, Critical Care Medicine, Pain Management, and Hyperbaric Medicine at Inglewood Hospital and Medical Center in Inglewood, New Jersey.
It's okay.
He's also,
all right. There.
He's also adjunct clinical professor, Department of Anesthesiology, Medicine, and Surgery at Icahn School of Medicine at Mount Sinai, as well as clinical professor of anesthesiology at Rutgers, New Jersey Medical School in New Jersey.
I'm sorry, Majed. Please, I'm sorry. Jamila needs to welcome us as the conference chairman first.
Okay.
Because did you see
Jamila, you muted Jamila.
Yeah. So Jamila is our conference chairman.
She's muted.
So she needs to say her welcome.
Okay. I thought we were going to skip that.
No, it was inadvertent.
Hello, everyone. A very good morning, a very good afternoon, and a very good evening to all of you. Welcome to BMSS 2023. We are very thrilled to present another exciting and learning experience for all of you, featuring a diverse faculty of multidisciplinary experts. Over the next 3 days, we are committed to delivering a successful and insightful meeting that promises to be an invaluable learning experience. I am deeply honored to assume the role of chairman for the Bloodless Medicine and Surgical Society in 2023. Equally, it is a privilege for the Malaysian Society of Patient Blood Management to be affiliated with BMSS and SABAM. I extend my heartfelt gratitude to Nathaniel, Caroline, and all the esteemed members for granting us the opportunity to join this important field. We eagerly anticipate further collaborative efforts in the future. The theme for this meeting is compassion at the heart of bloodless medicine. In our quest for advancements in bloodless medicine, we remain steadfast in upholding our core values of respect, empathy, and patient-centered care. Compassion is the cornerstone of these values, guiding our innovation, education, and collaboration to enhance the well-being of those who depend on us. It is compassion that empowers us to transcend boundaries, share knowledge, and explore uncharted territories within our field. As we embark on this collective journey, let us always keep compassion at the forefront of our endeavors. I trust you will find the sessions engaging and you will seize the opportunity to learn and make meaningful changes to enhance patient care and outcomes. I wish to express my sincere gratitude to all our esteemed speakers for their passion, dedication, and their generous contribution of time to share their valuable knowledge and experiences with us. I would also like to extend my appreciation to Nathaniel, Sandy, and the entire organizing team for their unwavering support and relentless efforts in shaping this program. Thank you all for your presence and dedication to the cause. May God bless all of you. Thank you.
I'm very pleased. Let me join the conference chair in welcoming all to this conference. My name is Nathan Elisoro. At this moment, I am the president of the Bloodless Medicine Surgery Society, but I think not for much longer. So, dear colleagues, stakeholders, guests, and other attendees, I very much warmly welcome you all to this 2023 annual scientific conference of BMSS. So our annual meeting is an important forum for sharing, receiving, and disseminating scientific information on various aspects of bloodless medicine. This is our 9th annual meeting. So we have had 8 previous meetings focusing on various aspects of bloodless care. This time, the focus, as we heard, is on compassion, with the very apt theme, compassion, at the heart of bloodless medicine. Compassion, according to Merriam-Webster's dictionary, is a sympathetic consciousness of others' distress, together with a desire to alleviate it. So there are 2 components there. In other words, compassion adds to empathy, a desire to take action to help others in distress. Many clinicians around the world are motivated by compassion to express their empathy towards patients by actively employing their skills to help them. However, this is particularly so in bloodless medicine, as we shall learn at this meeting. Bloodless medicine we define as a provision of quality medical care without the use of allogenic blood, that is donor blood, with the aims of improving clinical outcomes and protecting patients' rights. While there is currently a push to employ the principles of bloodless medicine for all patients in order to improve clinical outcomes, the practice of bloodless medicine started as an advocacy for patients who decline blood transfusion to protect their rights and save their lives out of compassion for them. So we can say that compassion runs in the blood of clinicians who practice bloodless medicine, even today. Compassion is also being emphasized today in medical ethics, along with empathy, as you will hear from one of our speakers. Thus, by being compassionate towards their patients, clinicians who practice evidence-based bloodless medicine may be on a morally and ethically higher ground than those who do not. This meeting brings together the cream of such clinicians and stakeholders in the field of bloodless medicine to share with us their thoughts and teachings on the significance and importance of compassion in bloodless care and how it is properly expressed, including the ethical and legal ramifications of this policy. That these excellent clinicians and stakeholders are willing to share their knowledge freely in this forum at no cost to an international audience of eager attendees is in itself an act of compassion for which we are very thankful. No doubt the speakers have in mind that we should use the information that they share here to save the lives of our patients around the world. And so we shall, as an important way of saying thank you to them for coming out to speak to us, as well as a way of providing quality ethical medical care for our patients with improved outcomes and protection of patients' rights. Let's spare a moment to find out who we are and where we came from. So let us see, first of all, where did we come from? If technology obeys us, there should be a poll there. So you could choose your continent. And I'm particularly watching out for Antarctica, because that's where we're supposed to try to get some people from. Right. Okay, so right now, Africa is topping the charts. I'm going to end the poll now. So if anybody, yes, I'll end it. I'll end it now, and then we'll see the results. Ending the poll, I'm sharing the results. We'll do it better next time. So you can see we've got people from everywhere except Antarctica. Maybe we didn't give enough time for people from South America, but there are at least 3 there. So, okay. Jamila, were you able to see the result of the poll from there?
I think Jamila is muted.
Okay, so let's see
Someone
what
muted me.
profession.
Yeah, we saw the you displayed it for a short while.
Okay, so let's see what profession we're from. Wow, lots of nurses. Okay. The physicians.
Well, I just realized that the panelists cannot vote.
Oh yes, we have no voting rights. We are disenfranchised. All right.
Hi, Mandy.
So in a minute, I'll end it. So we shall do it, we'll allow longer time on the 3rd day. So let me share the results. So we can see, can you see the results?
Yes.
Right. So perhaps we didn't give some more time. I think, okay, the lawyer we have here is on the panel. All right, finally, let's see how many people. Okay, let's see how many people have been here before. Okay, so this last one apparently is not launching. It's not launching. So we'll try launching. Technology is rebellious today.
Daniel,
Right.
sorry, can I ask, what is perfusionist?
So please stay with us all 3 days of this virtual meeting and listen to some of the finest medical minds in the world discussing a variety of important principles underlying the modern practice of bloodless medicine and their relationship to compassion for our patients. This meeting is being live streamed on BMS's YouTube channel, and we'll be able to review the material again afterward. So even as our heart is critical and indispensable to our existence and survival, so also is compassion, an essential and inalienable component of ethical practice of bloodless medicine. Thank you for coming to join the discussion of this important life-saving subject. We wish you all an enjoyable and fruitful learning experience at BMSS 2023. So I'll hand over to my jet now, Dr. Refai, who was trying to introduce our first keynote speaker. I'm sorry, Dr. Refai, you're just being drafted into this.
Thanks, Nathaniel. Sorry, guys, I'm not the moderator for this meeting today, but I can help with presenting just the first one because I have a meeting after this. I'm just going to present Dr. Ari Shander. He's an emeritus chair, Department of Anesthesiology, Critical Care Medicine, Pain Management, and Hyperbaric Medicine at Inglewood Hospital and Medical Center in Inglewood, New Jersey. He's also adjunct clinical professor, Department of Anesthesiology, Medicine and Surgery at Icahn School of Medicine at Mount Sinai, as well as clinical professor of anesthesiology at Rutgers, New Jersey Medical School in New Jersey. Dr. Shander served as the executive medical director of the Institute for Patients' Blood Management and Bloodless Medicine and Surgery at Inglewood Hospital, and as president of the Society for the Advancement of Patients' Blood Management. He serves as the director for education for team health. Dr. Shander lectures nationally and internationally on a variety of topics related to anesthesiology, critical care medicine, and patients' blood management. And his more than 200 peer-reviewed publications have appeared in several prestigious peer-reviewed medical journals. His publications are in the top 5% of the most read authors for academia. In 1997, Dr. Shander was recognized by Time magazine as one of the America's heroes of medicine. In 2015, he was the recipient of Inglewood Hospital and Medical Center Foundation's highest honor, the Touchstone Award, in recognition of his commitment in EHMC. In 2019, Dr. Shander received the Award of Excellence of the Bloodless Medicine and Surgery Society for his excellent contributions to the science and practice of blood medicine and surgery. And he has an annual lecture named after him by the Society, the PMSS Ari Shander Lecture. With this, I'll give it to you, Dr. Shander. And sorry, you have a long bio, which took some of your time for the presentation. So you have until 8:50, Dr. Shander.
Thank you so much, Majed. And as you were presenting the introduction, I was wondering how long we've known each other, and it's been quite a while. So again, thank you. Also, I want to thank Jamila for putting the context together, which in terms of compassion, and of course, Nathaniel took the thunder off my talk. So again, some of it will be repetition. But before I start, it's clearly not just a pleasure for me to see everyone, but it's as always an honor to participate in this particular meeting and to again be a part of this group. I'm not sure who actually came up with the topic, compassion at the heart of bloodless medicine and surgery, but that was the topic that I was given, as you see from the title of my first slide, and I hope you could see the slide. I think that we are immersed in...
Shander, could you change the view to make it, yeah, up there? Exactly.
Okay,
got it.
so things changed over since we last spoke. Anyway, I think that we as healthcare providers sort of live sometimes in a cocoon of healthcare, and those of us who work in both patient blood management as well as bloodless medicine and surgery also have sort of a very local view of what it is that we do, but we need to put compassion, I think, in a global environment rather than just looking at a local environment. And the world, of course, is no stranger to both violence as well as atrocities. And I think that we would be remiss not, again, mentioning the fact that we could all, meaning the whole world, can use a dose of compassion. As we get and perfect violence, as we've seen over the last few weeks, and of course, times before that, it really puts into perspective a lot of what we do in terms of caring for people. And I think that it's important for us to always remember that violence begets violence and never solves a problem. There's an old Chinese proverb that says that if you're out for revenge, make sure you take 2 coffins, not 1. So again, we don't see any positive effect, and no one's right when it comes to violence, regardless of how you want to rationalize who's right and who's wrong. So I think putting all that in context, we need to know that everybody has a right. All people on this world who are born into this world have the right of existence. And it's us who need to ring the bell again of compassion and understanding rather than continuing this cycle, which ends up not just harming the world, but clearly individuals who have nothing to do with the violence. So I'm sorry, but I think that we do have to make a mention of these events before we start. So as we move on, My talk today is to look at the definition of compassion and empathy, which you've heard already from Nathaniel before, but looking at it from the implications of healthcare professionals, which we all are. Again, talking about compassion, empathy, and bloodless care, how those three elements fit together. And there was a question in the literature that is it really needed? Is compassion and empathy needed in healthcare? Meaning, can we still provide good healthcare, or as mentioned before, the best type of healthcare without compassion? And I think that that's a question that needs to be addressed. Then I'm going to move on to, can compassion and empathy be learned? Because if it can, I think we have a duty then to include that in what we do when we talk to people about bloodless care, and we talk about any patient blood management or any part of healthcare, that there are ways that we can actually teach people to be compassionate and empathetic. And then as we look at the learning part of that, we need to know what the elements that actually work to adopt compassion into daily practice, meaning what is it that we need to address with individuals as we're teaching them in the most effective way for them to become more compassionate, understanding, and empathetic when they are actually caring for each one of us as human beings. And of course, we'll finish with the message, which is compassion is at the heart of bloodless medicine and surgery. Well, you've heard already before from Nathaniel, what is compassion? So when we go back to the different types of dictionaries out there, there are a couple of definitions, but according to the Oxford English Language Dictionary, those who work in etymology, which is the origin of language and words, ascribe or describe compassion as a 14th century term from Latin, which is com and pati, which equals to bear and suffer. So the meaning has evolved over the years, I think, but as you could see, that trying to put together the history of compassion, I dare to say, though, that I think compassion has probably been around for those of us who are believers since creation and those who are skeptics since the beginning of time. Because even when we had to, say, overcome an animal so that we can have protein, meat protein, there was always some kind of compassion with that in the form of thanks, whether it was a thanks to the Almighty or thanks to the fact that this was available through biology, whatever the thank you was, it had that element of compassion. So that the 14th century may have sort of narrowed that down to specific activity, which we'll get to in a minute. This includes, of course, as you see, the word sympathetic, the word pity and concern for the suffering or the misfortune of others. So compassion, again, when it comes to human elements or the human beings, clearly has much more of a halo around it than just understanding the suffering of individuals, but also the reaction that we have to that, whether it be a positive or a negative. This was an example from the Oxford English Language Dictionary. They say, putting it into a sentence, the victims should be treated with compassion. I think that it's not just the victims. I think that there's probably room for compassion for everyone around, and we just have to find that thread where compassion can be applied, even in times when the person who we're dealing with may not be a victim. So what entered into the compassion world, if you will, in terms of etymology or as I said, the evolution of language, is the word empathy, which is coined, I think, or has been included as part of compassion, or even the other side, meaning the other side of the mirror or the other side of the coin in the 20th century. Again, going back to the dictionary, when you're looking at compassion and empathy, a caring response to someone else's distress, empathy refers to an active sharing in emotional experience of the other person. Compassion adds to that emotional experience a desire to alleviate the person's distress. So it's sort of a combination, if you will, in my mind, of do no harm, or actually do good. So you need to not just do no harm. That is insufficient, and you've heard me say that before. You need to have the action part, which is do good. So we're both expected as healthcare professionals to have the understanding of the empathy, which is the sharing of emotional experience, but then we need to have the active part of it, which is to alleviate that person's distress. Now, that could be physical, or it could be mental, or together, maybe both of them. So again, examples is empathy. I feel your pain, and compassion. I value your concern and willing to make things better. I think that sort of puts it into perspective. So what are the implications for healthcare providers like us? Well, compassion. I'm sorry. Compassion is a core value of healthcare that includes, of course, empathy, as we talked about before, understanding. Understanding is clearly a global term, if you will, which can extend from any small particular understanding of what you're saying to understanding where you actually stand in the world, as mentioned earlier today. Giving it some perspective so that you can now at least address this individual's concerns, whether it be personal concerns or whether it be social concerns. Care for well-being of people. Again, I think that that's an important element of compassion as a core value. And again, it becomes a form of substitution. Here's if you will, the example of what we call an ethic substitution is to put oneself in the shoes of another, trying to understand what it is that another person is going through, whether it be physically or emotionally, trying to put ourselves in their shoes, if you will, or in their position. Not an easy thing to do, but something that we're called on to do in many, many ways. And that's something that can actually be learned. Understanding patients' fear, pain, and concerns clearly is part of the compassion as we break it down, and providing emotional support in conjunction with medical care is utmost important, because it is not just delivering the actual mechanical medical care. It's really seeing the person through that care by understanding what are some of their concerns and their goals actually in terms of therapy. So compassionate healthcare professionals treat both physical ailment and emotional and psychosocial needs of every patient. Now, as you all know, that's probably not a true statement, because that doesn't always happen. However, we may be able to separate this out to different people, because care of a patient is not by one individual, it's by a team. So different team members can actually own these parts of this particular statement that you see in yellow at the bottom of the slide. So what are, again, the implications for healthcare? As mentioned, compassion is an essential component of patient-centered care. And what we do when we do bloodless care and what we do when we do patient blood management is patient-centered care. Hence, we cannot move without having compassion in the center of what we're doing. It actually allows for positive impact on all overall healing of process of any kind of individual, whether it be, again, physical or psychological. And it leads to improving patient satisfaction, something which we now have learned to value as a part of delivery of care, in terms of looking back to see how the patient actually went through the journey of healthcare and whether they were satisfied with everything that they actually received in terms of their expectations coming into healthcare, and of course the expectations that they have with them leaving the journey throughout healthcare. Now we move on to bloodless care and trying to put this in the context of compassion. So again, most of us identify bloodless care as a care of Jehovah's Witness patients, but in fact, as we know, that bloodless care is defined in terms of patients for whom blood is not an option as a therapeutic intervention. So there are other individuals, those who are concerned with the risk of allogeneic blood. Again, the numbers are small, and there are other religions that may actually evolve into individuals deciding to decline the treatment with blood. The underlying medical issue, of course, is that no transfusion of any major blood components, making it an issue for healthcare providers who are under the impression, again, that all blood, again, may actually confer benefit at very little risk. So ultimately for patients, as I said, it's making an issue for healthcare providers and ultimately for patients if and when compassion and empathy are ignored. So if we don't understand the concerns that patients have, especially those patients for whom blood is not an option, and we, again, do not approach them with compassion and empathy, this creates a conflict which, again, can ruin the experience of a patient, but actually can harm them both physically as well as emotionally as they go through the journey of their care. Not placing your feet in another person's shoes leads to confrontation and poor care, resulting in poor outcome. As a matter of fact, we know that when that happens, outcome of patients may actually be their demise. And we've seen that time and time again. So we can't really put compassion in the backseat as something which is soft data, if you will. We need to bring it to the front row because, as you know, if the care lacks compassion or empathy, and the desire and the goals of the patients are ignored as a result of that, it can actually lead to their demise. Compassion plays a crucial role in the context of bloodless care. It's having a unique needs and concerns. Bloodless patients have a requirement that healthcare providers need to meet, the requirement that they need to meet, including understanding where the patient's goals are. Their autonomy must be respected. And again, understanding that each one of us has the ability to, again, exercise our autonomy over our body. Respect of beliefs. It doesn't mean that you have to agree with them. But what you need to do is that everyone has a right to existence and everyone has the right to believe. And in fact, understanding the belief may open your mind to new horizons. It's not just rejecting it right off because you don't believe in something that another individual does. A willingness to explore other modalities for care befitting the requirements. Again, if you're allergic to a medication, we need to search for something else. If a particular intervention in medicine does not fit that patient's goals, we need to search for others. We may not be able to find them, but we can come back to the patient with compassion and understanding and be able to communicate with them our efforts, as well as the fact that there was respect for their autonomy and beliefs. Again, assuring their safety and well-being in what could be a hostile environment, which can occur very, very quickly if the two are expressing different beliefs and different goals for their care, and again, where compassion and sympathy and empathy are not being exercised. A compassionate approach to the bloodless patient involves open communication, and that is probably the first rule. The open communication means that the clinician can actually discuss their position in a pretty open way, to have the patient also understand if there is a conflict, but also to understand and draw from the patients what they believe and what their expectations are. An all-out effort to understand the patient's preferences and values. By doing such, meaning the all-out effort, what will happen is we can align our preferences and values with the patient and come up to an understanding in terms of what course we're going to take with that patient care. A commitment to find the best possible medical solution that align with the patient's preferences and values. You heard the same from the previous introductions. This is an important element when we talk about bloodless and compassion. So aligning both patients and healthcare professional preferences is not just important, it is crucial for good outcome in the care of the bloodless patient, and in fact, in the care of any patient. So moving on to further on compassion and bloodless, compassion is a core value in healthcare that applies universally. So you mentioned that already before, but I think it's well worth repeating that the fact that compassion needs to be applied universally, not just in bloodless or any other form that we're dealing with. But bloodless care is a specialized approach that caters to patients' special needs. Under those circumstances, we're now coning it and narrowing down to the bloodless patient. Compassionate healthcare providers can and must adopt their approach in order, or adapt their approach in order to provide the best possible care. So there is a need for adjustment. The fact is that we sometimes come into a situation where we're completely rigid. Opening ourselves to communication with a patient and understanding where they come from will help us adapt again to something which we may have not been thinking about before, but needs to be addressed if we're going to deliver and meet the patient's expectations. They have to be, of course, reasonable. In some situations, some healthcare providers may not value patients' preferences and may see them as negating good clinical practice. So again, this is providing the ability to adapt under those circumstances, which is not very easy to do for many healthcare providers who may be armed with misinformation. These circumstances call for patients' advocacy and for healthcare providers to advocate for bloodless patients by ensuring their safety, while their preferences for special care are accommodated while providing the best medical care, which also includes the ability to recognize that I, as a healthcare professional, cannot provide the care that you're looking for, and also be open enough to say, I am not able to adapt, but I will find somebody who can. It is essential for us to do that. And unfortunately, my experience over the years has been that many have neglected the patient in terms of this advocacy issue and let them linger in many ways suffering without the appropriate help. So is compassion universal in healthcare? Empathy and compassion are vital components of healthcare quality. However, physicians frequently miss opportunities for empathy and compassion in patients' care, not because they don't care. It's just that they miss the opportunity where they can actually interject compassion and empathy in such a way that will help the patient, but also help the clinician. Despite evidence that empathy and compassion training can be effective, the specific behaviors that should be taught remain unclear. So this goes back to what we mentioned early on in the introduction, is the impact of the learning of compassion and empathy. So here's a publication that came out, the American Journal of Medicine, the so-called Green Journal, Empathy in Medicine. What is it? How much we really need it? And just to quote from this particular manuscript, it says that empathy plays a critical role in the physician-patient relationship and has a positive impact on health outcome. Again, I think that this is something that repeats itself over and over again. However, as the field of empathy expands, the lack of conceptual coherence challenges advances in medicine. In fact, in some medical setting, there is little added theoretical or clinical value in applying all encompassing term of empathy, which is by nature multidimensional, interpersonal, and modulated by context. So again, you need to read the room is essentially what we're saying. Functional neuroimaging studies of health professionals designed to examine patterns of brain activation in response to empathy eliciting situation bring theoretical clarity to the neurocognitive mechanisms that underlie interpersonal sensitivity, emotional empathy, cognitive empathy, and caring. These components are relatively independent, but often interactive and deeply interwoven in the fabric of brain. So again, this is a thinking process, not just a heart process in it. So when we look at the anatomy of empathy and compassion, empathy should be broken down into its component. Again, by breaking it down, we can actually address those different components. These components refer to distinct psychological process that vary in the function of neurobiological mechanism. There's a critical analysis of functional neuroimaging studies with health professional that calls for a nuanced assessment of empathy function in medicine. We can actually identify the anatomy, if you will, or functional anatomy of the brain. The positive effect of patients, physicians' perceived empathy can be explained by the synergy between social baseline theory and predictive process of neural inference. So again, it's emotional empathy necessary in medicine was another publication that came out looking at some authors argue that minimal amount of emotional empathy is needed to help physicians understand the subjective states of their patient. So we need, again, a threshold of some emotional empathy. On the other hand, too much emotional empathy can lead to burnout and compassion fatigue, which are not usually associated with empathetic concern. So again, overdoing it may actually reduce empathy or may actually turn on the individual healthcare provider with burnout. Practitioners who are most vulnerable to burnout, which leads to detachment and low sense of accomplishment, again, the antithesis of compassion, may find it difficult to regulate their negative emotions and maintain a clear distinction between self and others. This is where we need to be compassionate with our colleagues. It's not just the patients. So again, the call for compassion is going to help in this particular devastating situation of burnout. Nevertheless, an important question remains as to whether the capacity to be affected by observable or inferred affective experience of others, that is emotional empathy, is necessary. This is again from the same article, and I'm not going to belabor because of time, but you could see that there are multiple areas in the brain that are elicited both by the person who is being compassionate and those who are receiving the compassion, so that the brain is responsive. So this is not just a soft, if you will, heart type approach, but there is some hard evidence, for the lack of a different term, to show that this is actually has some function with related anatomical locations that are described over here in this particular slide. So there's got to be a sober perspective on empathy. It goes without saying that patients expect their doctor to be human, attentive, warm, caring, communicative, and understanding. These qualities of empathetic concern, sympathy, and compassion in contemporary medicine are of paramount importance for clinical practice. Again, the same message over and over again. Specific biological mechanisms explain their positive effect on patients. These qualities, rather than the incongruous ideas of emotional sharing and imaging, what the patient feels, or imagining, what the patient feels, should be cultivated in medical education. So again, we know that these things can be learned, and it's important for us to identify how to teach them. So in addition, it's important that physicians are comfortable with themselves and feel safe so that they can be more open to others and express caring attitude, again, without overdoing it. This is a publication from 2018 from PLOS ONE, Curricula for Empathy and Compassion, Training in Medical Education. This was a systematic review, and they looked at multiple different behaviors from this particular group that looked at this. This is came out of New Jersey. It looked at behavior that was identified in 52 studies. And they're listed here, not necessarily in hierarchy, but to understand that sitting during an interview shows that you're connected with the patient and is not only empathetic, compassionate, but also creates an understanding. Detecting non-verbal cues of emotion. Facial expressions are almost important to be able to read on both sides. People read them from both sides. And again, they should be followed with explanations, not just leaving somebody to wonder whether they have an emotional, that is, that the emotion that's created by facial expression is the end of it. Recognize an opportunity for compassion. When is it that you can stop for a minute and address the patient's concerns? nonverbal communication will already addressed with nonverbal cues, and the validation support statement. Again, trying to make sure the patient understands that we understand what it is that they're going through or what their expectations are. And these were some of the number of studies that they looked at. And in black is what was successful, and the gray was not so successful. And you could see the standardized patients is very important, as well as role playing. The small groups in terms of looking at response from patients may not be as successful as we'd like. And of course, didactic is important to set the stage as we're doing today, but role playing as well as standardizing approach to patient is extremely important. So they summarize that the current evidence suggests that training can be enhanced, can enhance physician empathy and compassion. Again, this report has collated the medical education literature, skills, and behavior that enhance physicians' empathy and compassion, improve the framework for which research and educators can develop evidence-based curricula. As I'm moving towards the end, what works for whom in compassionate training program? Again, the same question, looking at a large number of, this is called the realistic review. You could see large number of manuscripts for review, and the 43 were analyzed. You could see the different elements that go into teaching, if you will, compassion and empathy, and of course the results in doing it. It's too busy for us to go through this in detail, but these slides will be available. And at the end of the day, they concluded that, again, you need to be able to break it down into different elements as shown in the previous slide. And again, that can be taught and can create a sustained culture of compassion in healthcare if the whole institution, meaning everyone together, works to create a culture of compassion and empathy. So to end, compassionate at the heart of bloodless medicine and surgery. Again, this is a universal core value in healthcare. Special needs such as bloodless care need adoption across the board of both compassion and empathy. Too little or too, sorry for the misspelling, but too little or too much compassion can result in negative outcome, as already shown. But there's also room for compassion for those who have suffered from too much. Training and education must be ongoing and integral part of all healthcare professional. And lastly, compassion must be a value that is interjected at all levels of care, and of care as well as the institution that's providing that particular care. And with that, I would thank you.
Thank you very much, Dr. Shander, for your talk this morning. I will now turn it over to Nathaniel Usoro to introduce our R.A. Shander lecturer for the 5th annual BMSS meeting.
Nathaniel, you're muted. There you go.
Yeah, thank you very much, Dr. Soidan. For the purpose of the introduction, I'm going to share a slide. I'm going to share some slides with you. And let me seize this opportunity to thank very much Dr. Shander for that fantastic talk. Yes, I did have a peek at his slides, so I had advanced knowledge. Right, so we now coming to the 5th BMSS R.A. Shander lecture, which is a very special lecture for us. It has been a feature of our annual meeting since 2019, and the aim is to encourage the improvement of clinical outcomes and protection of patients' rights through promotion of the science and practice of bloodless medicine and surgery. The BMSS R.A. Shander lecturer is usually a person with a track record of outstanding academic and or clinical work in bloodless medicine and surgery. Dr. Shander himself definitely fits the bill, and he was our very first BMSS R.A. Shander lecturer. Dr. Shander has traveled all over the world teaching bloodless care, patient blood management, and he has come as far as Africa here to Calabar, Nigeria, as you can see in the picture. And that was in 2019. So today we have a very special person with us as the 5th BMSS Shander lecturer, and that is Dr. Jonathan Waters. He is going to speak on the topic Bloodless Care with Compassion in Obstetric Anesthesiology. But first, a little about him. We had to cut everything down so that he would have enough time to talk. But we need to know that he's a professor in the departments of anesthesiology and bioengineering at the University of Pittsburgh. He is the chief of the division of anesthesiology at Magee Women's Hospital of the University of Pittsburgh Medical Center. And he's a member of the McGowan Institute for Regenerative Medicine. So Dr. Waters is the medical director of the Patient Blood Management Program of the University of Pittsburgh Medical Center and the medical director of the Blood Management Division for Proseca Incorporated, which is a UPMC-owned biomedical engineering company. His area of expertise primarily focuses on transfusion management and blood salvage and obstetrics. He has received a lot of federally funded support to investigate these areas with over 150 peer-reviewed publications, 5 books on the topic of blood management, and a book on neurologic disease in pregnancy. Dr. Waters has served on the editorial board of the journal Transfusion, which you know is a very reputable journal on the subject, and he's currently serving as the associate editor of that journal. He's the past president of the Society for the Advancement of Patient Blood Management, SABM, and he served on the board of directors of AABB between 2011 and 2015. He also chaired the Blood Management Technical Advisory Panel for the Joint Commission from 2007 to 2016. And so I present to you, ladies and gentlemen, Dr. Jonathan Waters, our 5th BMSS Shander lecturer. Dr. Waters.
Thank you, Nathaniel, for that nice introduction, and thank you for inviting me to speak here. Can you hear me okay?
Yes, very well.
I'm going to share my slides. And hopefully you can all see that. There we go. Is the slide coming through?
Yes, it has.
Okay, wonderful. Just want to say that I had taken the day off to attend this conference today, but because of staffing shortages, which seem to be something that's pervasive across the United States, I was called into the operating room to do cases. So if I get interrupted during the course of my presentation, I apologize in advance. You can think of my stethoscope as my tie, which I would ordinarily be wearing. At any rate, it is very difficult to follow Dr. Shander, the godfather of bloodless medicine. He is kind of a god in the circles of bloodless care. So it is a great honor to be giving this presentation, the R.A. Shander lecture. At any rate, I was asked to speak on compassion and obstetric anesthesiology, and I struggled with this title. Compassion is something that we don't think of. I think it's something that comes innately for some of us and not so innately in others. But anyway, Nathaniel already took a couple of my first slides. These are some of my disclosures. I do some work with Hemonetics, which is one of the cell salvage companies. LivaNova is a competitor. Vitalant is a company that provides blood to 19 states in the United States. And I'm also the medical director of Biotronics, which is our bioengineering company for the University of Pittsburgh. So I started off, looking at what exactly the meaning of compassion is. And this is what I found on Wikipedia, is that it means, that you have a deep understanding of another person's pain and burden, accompanied by a willingness to relieve them. And there's been a term that's sprouted out of this compassion. It's called compassionate care, which has been determined to lead to higher satisfactions for patients, happiness during the course of their healthcare experience. These are all things that at least I value greatly, and I'd like to think that I'm a compassionate leader and healthcare provider. However, it's not so easy. And a number of years ago, I ran across an individual, Paul Ulick, who is a cardiac surgeon at the University of Kansas. And he had teamed up with a social psychologist, Ellen Rabowin, who is a sociologist at Stanford University. And they put together this book on implementation of collaborative practice. At least for me, that's been kind of earth-shaking in terms of how we go about organizing our healthcare entities, so that we do provide compassionate care. And what Ellen and Paul, their key concept is that we need to recognize social circles, is that we're all very social animals, and that we need to nurture the social environment that we practice within, and which in turn leads to happiness on the part of the healthcare providers, which gets translated to the patients. And so this concept of collaborative care is highlighted here, but it's basically, based on sharing communication so that everybody is on the same page. And in my organization, we had a problem, at least in labor and delivery, with getting our first case started. Our on-time start was about 8% of the time where we would start our OR cases on time. 8%. It's horrible. It was a dissatisfier to all the providers. It made them very jaded, as to the system and its dysfunction. It made our patients unhappy. So we started a huddle based on the concepts that Ellen and Paul propagated in their collaborative care book, which, by the way, is available if you do a Google search on their names. It will come up as a book that you can purchase, and I would highly recommend it. It's really kind of a novel way of approaching healthcare organization, believe it or not, where we focus on the fact that people taking care of people are people. So what we did is we started a morning huddle before our operating room day started, and we invited everybody that participated in the care of our patients. And this is a picture of one of our huddles, and you can see a lot of smiles, because that's what it generated, is that this camaraderie that came from meeting together before the start of the OR day was something that everybody felt was valuable. And we went from an 8% on-time start to 100% on-time start within a matter of about 3 weeks, just from getting together as a team and discussing all of the problems that each of us would be facing that particular day. And that's, I think, kind of at the heart of providing compassionate care, is being happy ourselves. the part that we neglected really was the patient. And I think a patient, is a key component to collaborative care and compassionate care. As we go about caring for these people that are sick, and it's a particularly trying time, with the idea being that all the providers, the family members, and the patient all gather at one point in the course of the day, and we get together and share, first of all, the patient's perspective on how things are going, the family's perspective, and then what the healthcare team is planning to do for that patient. And this eliminates a lot of misinformation and miscommunication, as if everybody is collaborating together with the single focus of being the patient. And I think that's truly what composes compassionate care, is focusing on what's valuable to that particular patient. So with the bloodless patient, it's something that is unique to this particular patient population, but I think it's important, to get together with that patient and discuss what's important to them. And as we all know, being transfused is something that they don't want. So we need to have a structure and foundation as to how we go about taking care of these patients. And I just have some data here, regarding the size of the Jehovah's Witness population. And I just want to point out that in this latest decade, we have a new population of bloodless patients. They are patients that will agree to a transfusion, but they don't want blood from patients who have been vaccinated with COVID. So while they'll accept a blood transfusion, it's about 25% of our patient population now that request a bloodless care. So this is really important for me in my practice because the Jehovah's Witness Church was founded in Pittsburgh back in 1872, I believe. This is a plaque memorializing the foundation of the church here. It happens to be next to our football stadium, which is another place that we pray every week. More lately than in the past, because our football team kind of stinks. But at any rate, these are the tenets by which the Jehovah's Witnesses base their beliefs. I'm sure I'm speaking to the choir here. At any rate, one of the first things that we recognized when we built our program was we needed to have a mechanism for identifying our bloodless patients when they came into our hospital. And we had a couple of lawsuits that were filed because we didn't recognize Jehovah's Witnesses and we didn't treat them the way they wanted to be treated. So now what we have is a series of questions that are placed or made to the patient as they're being admitted to our hospital. And one of these is in the middle of this slide as to whether or not a blood transfusion would be acceptable. And we basically had to wordsmith the language on this for quite a while, and quite a few permutations it took, because nobody wants to be transfused if they can help it. So we would get no responses frequently, and it was overwhelming to differentiate who was truly willing to avoid a blood transfusion if it was deemed necessary, versus who would just prefer not to be transfused. So I think we all share that general perception, is that we want to avoid transfusion if we can do so. There's also a question on our nursing admission sheet, as is shown here, about whether or not the patient would like for an advocate from our Bloodless Medicine program to speak with them. And, this is the result. So we also had another mechanism that we developed within our computerized information systems where a physician could order a consult from our Bloodless Medicine program if a patient is achieving what we would consider dangerous levels of anemia and they have this bloodless desire. So it's important that every patient be educated, as to what blood products are available. And I think for most patients, the red cells, the white cells, the platelets, and plasma are considered, absolute not products that they would accept. But some of these conscious matters or the fractions require a conversation, first of all, to explain to the patient what they are, and whether or not they're manufactured and how they're manufactured, because everybody has different perspectives on whether or not these are okay. So we have two bloodless medicine advocates. This is the leader shown here, Debbie Tatro, who is the kind of the spearhead of our bloodless medicine program. And she talks to pretty much every, bloodless patient that's identified on our nursing admission form to distinguish, what their requirements are, or what their needs are, so that the rest of us, caring for these patients are able to meet their wishes. This has led to 411 inpatient consults back in 2018. Most recently, we're up to about 1,500 consults per year for our bloodless medicine program. And what Debbie does is she goes through a list of the kinds of things that meet these criteria of being conscious matters, of what patients might accept and what they might not. And this is a sample of the checklist that we give to our patients that they can carry around with them in their wallet, so that when they come into the hospital, they can hand this to their providers, so that everybody is on the same page, so that we can provide the care that the patient wishes. We also put a note into our medical record, and an example of this note is shown here, so that everybody taking care of this patient knows what the patient's wishes might be. We've also got a fairly detailed list of online materials that are available for the clinician. As is shown here, we have an advocacy service, which I just described. We have a consultation service, which I'm the primary consultant, along with Daryl Traulzi, who's our medical director of our blood bank. He and I provide medical consultation to our clinicians caring for these patients if they so need it. And these are some of the resources that we have available. And we have something called HBOC 201, which is Hemopure, which is an artificial blood which we can provide to our patients. This is a non-FDA approved product, but it can be life-saving in some circumstances. Now, I've come to become very reliant on our hospital liaison committee. This is some information about our hospital liaison committee. Whenever we have a patient that doesn't trust us, we involve the liaison that's assigned to our hospital, so that we can bring in somebody to consult with the patient and explain from a layman's perspective, how we're going to care for that patient. And I think that's been hugely important, in our ability to respect the patient's wishes and to provide the compassionate care. This is just latest data for the last quarter. And we've got this program across all of our hospitals. And I think we have 58 hospitals within the UPMC system that provide some degree of bloodless medicine for our patients. And then we've been rolling out some new projects, as is illustrated here. So my slide set was supposed to be about bloodless obstetrical care. So what can we do in the obstetrical environment? And what we see here in the United States, at least, and I think this is true of the world, is there's an increasing maternal mortality rate. And this is some data as to the causes of death. This comes from the CDC, the Center for Disease Control in the United States, across all states in the United States, all 50 states. And you can see hemorrhages is number 4 in the causes of death. But I think what's more important to look at is basically coagulation dysfunction as a category in and of itself, because women die not only from hemorrhage, but they also die of too much clotting, and leads to DVTs and pulmonary emboli. So this is a spectrum in my mind of dysfunction that is the leading cause of death in the United States during childbirth. If you look at or drill down into individual states, the leading causes of death change. And in this report, we found that hemorrhage was the leading cause of death. And in the state of California, maternal mortality rates are extraordinary. It's around 200 maternal deaths for every 100,000 patients, which, if you think of it in a different way, it's one maternal death for every 5,000 patients. And if you look at this data from California, obstetrical hemorrhage has the greatest chance of preventing that death. So what can we do? And in the Jehovah's Witness patient, I try to think about what I can do to offer alternatives to blood products, the primary blood components. And these are some of the things that we can offer to our patients that get around or are able to avoid the whole blood components. And autotransfusion, as many of you probably know, is kind of my passion. Autotransfusion, otherwise known as cell salvage, has been basically adopted and advocated by these organizations. It was first pioneered in 1874 by this physician, William Highmore, who at the end of this article in the Lancet said this is basically the way we prevent hemorrhagic death is we collect blood from the bleeding patient and we retransfuse it. And I think in many parts of the third world, this is still the case, and how we should approach these patients is just collect the blood and put it back in them. In the United States, we have these fancy machines where we can wash, filter, and reperfuse patients with the blood that they've shed. In this particular device, the leukocyte depletion filter alleviates a lot of the fear that many clinicians have with this autotransfusion process, and that this filter will remove a lot of things that we're afraid of. Now, we have expanded our autotransfusion program to using it in vaginal deliveries, which is 70% of all deliveries in American hospitals. And it's a rich opportunity for giving blood back. And this was a report that came out of England where they looked at bacterial contamination, which is the fear of most people in doing this or doing autotransfusion and vaginal delivery. I mean, you can see there is some bacterial contamination based on this investigator's work. And it's of these bacteria. The thing is that these patients are already exposed to these bacteria. So we looked at a case series in our hospital of 64 patients that had vaginally contaminated blood reinfused, and we found that the outcomes were equivalent, as is shown in this slide. We published this in Blood Transfusion, which is the Italian journal of blood management, or rather of transfusion medicine, where we found no outcome differences in our patients that were transfused with their own vaginally collected blood. How we do it, we use a double collection system where we collect the amniotic fluid and discard that amniotic fluid, and then we collect all the rest of the blood. And then we use this device in all of our labor rooms where we can collect blood inexpensively and give it back to the patients. So other things that we can do for our OB patient population is we can focus on anemia. This is a problem that pretty much assigns patients to whether or not they'll need to be transfused or not. If they come in with a hemoglobin of 6.5, odds are, that the blood loss tolerated or occurring during delivery will put them at risk of needing a transfusion. So, and it's a really simple thing to fix. The cost is cheap. Even if we go for intravenous drugs or iron supplements, such as shown here in American hospitals, a Fairlesset dose is about $9, which is super inexpensive. So I've gotten our obstetricians to be doing this much more frequently so that we don't have patients coming to us anemic and iron deficient. There's probably not much role for erythropoietin in pregnancy, just because normal erythropoietin levels during pregnancy go up. So supplementing it, unless the patient has renal insufficiency where they're not able to increase their erythropoietin concentrations, it's probably a waste of time. Some of the plasma substitutes, these are pharmaceuticals basically that we can use in the bleeding patient, I think is something that I've come to recognize as being really important. And we have Riostat, which is a fibrinogen concentrate. That's a pharmaceutical that most of our bloodless patients will accept because it's been manufactured. We also have other products, Kcentra, which is a 4-factor PCC. It might be mislabeled as a 4-factor PCC. It's actually 6 factors that you can give, again, something that's manufactured and would be deemed a pharmaceutical. And then we have Octoplas, which is a pool plasma product that if it's explained to the patient that this is also manufactured and is, at least in my mind, a pharmaceutical, this is oftentimes acceptable too. So I will leave you at this point with a picture that I'm quite fond of, that one of the daughters of one of the Jehovah's Witnesses that we took care of drew for me. Her name's London, and her mother may be watching today. At any rate, I thought this was very special, that she would take the time out and draw this picture for me. And I will finish there. And thank you all for listening.
Thank you very much, Dr. Walters. Our next talk will be our second keynote address from Sherry Ozawa, entitled Compassion and Nursing in Bloodless Medicine. Sherry Ozawa has been a leader in patient blood management and bloodless medicine for more than 2 decades. She has a background in critical care nursing, which has enabled her to help create one of the most widely known multidisciplinary PBM programs at Englewood Hospital in New Jersey. She's lectured internationally and throughout the US, and she focuses on creating and implementing sustainable organized PBM programs. She's very well published and continues to be actively involved in research in the field. She's also worked with the Joint Commission and other regulatory agencies to help advance patient blood management. She is currently she has served as an investigator on the first US federal government grant via the Department of Defense funding for creation of an organized training program for doctors and other healthcare professionals in patient blood management. She's a founding member and immediate past president for SABM, and she's currently serving as a director of comprehensive patient blood management delivery and operations for Acumen. This is a company that specializes in implementing comprehensive PBM programs across the US. She has also been selected as the only nurse contributor to the WHO PBM Policy Brief Implementation Panel. She's received awards of excellence, including the Award for Excellence of the BMSS in 2019. Sherry, we're happy to hear from you this morning.
Thank you, Erin, for the kind introduction. It's a pleasure to be with all of you. I appreciate the invitation and greetings from Skopje, Macedonia today. So I'm going to share my screen. I apologize that I'm just on a laptop here. So let's see. Let's go to, is that working? Can we see it? Okay.
Yes, you can see.
Yes, looks good.
Yeah, thank you. All right, awesome. Thanks, Erin. Thanks, Nat. Okay, so a little bit, again, background on compassion. We've heard a bit about it already from previous speakers, but I'm going to specifically tie this certainly to bloodless medicine and surgery, but also a few points specific to nursing history a little bit, and how our current environment that we all work in a sort of post-COVID world, but a world that was already strained in healthcare resources and lots of pressure on our healthcare providers, particularly nurses, and how that impacts what we do, and particularly in bloodless medicine. So you heard REA already referred certainly to this concept of patient-centered care, where this is the definition from what was formerly known as the Institute of Medicine, now the National Academy of Medicine. And I'm not going to read you all these words, but I kind of highlighted the things I think particularly tie to what we're talking about in bloodless care. And you'll hear me use PBM, as you've already heard, John and REA. You know, there's certainly a lot of crossover between PBM and bloodless. That's not the topic for today's talk. They're not interchangeable. There are, unique aspects to both, but there is a lot of overlap in the things we're doing in PBM and bloodless. And so you might hear some interchange of terms, but I think it'll be clear. But really for both PBM and bloodless, respecting and responding to our patients' preferences and needs and values, and acknowledging that our patients are not just moments in time and bodies in an exam room or in a bed. They have whole lives, right? And we're patients too sometimes, and they're made up of all their experiences, their stories, and their knowledge, and those have formed their values and affect the choices that they make. So again, using these terms, patient-centeredness and compassion, those are easy words to say, but you can see that no matter what country we are in or practicing, sometimes our systems use the words a lot, but when we see it in application, they're often built around other things, and logistics are the pressing needs and really our patients' care. And I think bloodless, again, for all these years has been a demonstration of how you can keep pointing back to the patient and keeping them at the center. So I'll speak a bit about, and I apologize, a couple of these slides are from my talk last year, not a lot of them, but I think because I was asked to speak specifically about where nursing and compassionate care and bloodless work together, a tiny bit of history on nursing. It really was highly gendered, which I'll talk about in a moment, but rooted in these vocational norms of motherhood and homemaking. And it evolved to the definition, the ability to be these three main C's: compassionate, caring, and communicative. And although we use the word compassion a lot now in healthcare, into sort of both with physicians, nurses, and others, it actually wasn't that commonly used in healthcare literature and healthcare settings actually until the HIV crisis. And I'll talk about more of that in a moment. But that is really how nursing has evolved to really embody, in part, compassion. And These are highly valued skills that are critical to, as we said a moment ago, patient-centered care. They're often perceived as sort of soft skills, but they're actually very, very deeply valued by patients and families. And as we already heard, are absolutely related to not only the patient experience, but also actual clinical and quality outcomes. So just some fun stuff right from the internet, because of course, we believe everything we see on the internet. This is the last time I could find this particular survey that talked about the most trusted professions in the United States. Nurses, every time they do this, every few years, nurses do come out up at the top, as you might imagine, Congress people and lawyers down at the bottom. And again, we also believe everything we see on Twitter. I just pulled this yesterday from this interesting feed, if you want to follow it, World of Statistics, and fascinating stuff that's shared. But it also sort of did this widespread global survey of who do we trust the most, and not surprisingly, nurses come up near the top, pharmacists higher, which was surprising, and down at the bottom, as usual, politicians, etc. But I think it's not a surprise to anyone in this call that nurses are seen as a very trusted profession, but that also comes with a lot of responsibility when it comes to certainly working with our colleagues, but most importantly, our patients and our families. So a little bit more history as nursing changed and evolved into what is now modern nursing. Those earliest nurses, as we described a moment ago, they actually never went to school, but things changed a lot during the 19th century. Their role was expanded to include soldiers during wartime, and during the 20th century, specialties started to develop, certainly as they exist in medicine. Formal schooling, and particular, again, nursing specialties and subspecialties like orthopedics, psychiatry, trauma, etc. And now, as we all know, advanced practice nurses, again, the practice may be different in different parts of the world, but it is very common, certainly, for nurses to be in advanced administrative roles, even being CEOs or chief clinical officers of large health systems in North America. But they may be in clinically facing roles, business roles, administrator roles, legal, ethical roles. So really a very, very fast evolution of the practice of nursing, and very expansive. Again, that's not the same in every country, but a lot of opportunities and diversity of practice. So back to the topic we're talking about today, compassionate care. And again, I pulled some things from specifically the nursing literature. And this was the definition as expressed in the nursing literature of compassion, this inner feeling of another person's suffering with the motivation to help and alleviate that suffering. And the four primary parts of that being wisdom, humanity, love, which I think is an interesting one. We don't often use the word love, right, in actually the clinical care that we exercise, but it is considered academically a part of what is defined as compassionate care, and empathy, which I think our previous speakers already captured. So what about specific to nursing and the term compassion, or the use of the word nursing? As I said a moment ago, and we're not here to have a gender discussion, but the challenge is that this is a very highly gendered history, both to the nursing values overall and to specifically the use of the word compassion. Not necessarily a bad thing. The history is what it is, but you can see from those vocational norms that it was a highly gendered experience. And these visions of nursing as a vocation steeped in caring, sympathy, and selflessness were at the heart of the transition, as we spoke about a moment ago, from a trade to a profession in the 18th century. And so on the right, you see really quite a fast progression. This is UK based, but in 1843, this is a depiction of a nurse named Gump, who was in a Charles Dickens novel, and she was a pretty saucy character who had questionable morals and did all kinds of interesting things, if you're a fan of English literature. But really, and that was sort of shaped in large part, at least over the pond here, that the perception of nursing as sort of this interesting little segment of society. But then just a few years later, Florence Nightingale, as you see in the bottom picture, began her career, became a nurse in 1851. And because of her work, both as a trialist, as a practitioner, all the work she did in the Crimean War and other parts of her career, really developed this as a profession, as the parent of the modern nursing as we see it today. So it was a very, very fast and interesting progression, but she is really the one who then brought into, in a professional sense, this concept of compassion, and tied together nursing to these other qualities: virtuousness, loving, kind, unselfish, gentle-hearted, as some of the terms that she used in her literature. So interesting history if you want to look at Dickens. So that term compassionate care, as I said a moment ago, was actually not that common, although again, we use the word a whole lot, certainly today, but through our care, the term compassionate care was not really applied to nursing until the 1970s. And then it started to appear a lot in the literature during the 1980s and in subsequent decades till now. But it started really, most of the articles refer to caring for people with HIV and AIDS. And it linked compassion in the nursing literature with incurable and stigmatized patients. I think it's an interesting point, not that we would classify our bloodless patients as incurable, right? They don't have a problem because they make choices around transfusion, but stigmatized for sure. So I think that we can learn some of the lessons of these years in a way that the term compassion is used alone, or not specifically about bloodless patients in these articles, but it's an interesting evolution of the term. From that same nursing literature, you see lots of diagrams. This is kind of the academic depiction of what does compassion and where does it fit into the structure of nursing practice. On the bottom, there's the whole practice environment, and compassion is sort of this underpinning foundational piece. Again, broken down into these patient-centered, individualized needs, et cetera, with communication as an important part of it, with the intention of alleviating suffering. So a visual depiction, again, of what compassion looks like in the nursing literature. This, of course, was well demonstrated. Again, sometimes these skills were perceived as soft skills. Don't love that really approach to things. And they didn't seem so soft, certainly during COVID, when nurses understood that need for human connection at a time where patients did not have their families or loved ones around them, and came up with all kinds of strategies. Just one in the picture we're all familiar with. When we were all behind shields and masks and all kinds of protective equipment, there was a real need for human connection. And again, those skills didn't seem so soft when this was the connection that patients, often sick and dying alone, had to other human beings. So how does that, again, we're here to talk about bloodless care today. How does some of those lessons and a little bit of that history relate to what we do, and those of us who are interested in specifically bloodless care? So many of the patients that we take care of in these types of settings and these programs have actually been, and I don't use the word lightly, traumatized in other healthcare settings, maybe traumatized by their own histories. As we said at the beginning, patient-centered care means our patients come with stories and history and experiences, and the history of this patient population, again, is long and has been very variable. So traumatized is not the wrong word. These patients have very specific values, value-based needs and preferences, as we've already discussed, and the communication around this must be delivered with sensitivity and compassion. We are asking patients to make real-time decisions based on long histories, right? And some deeply held personal values, maybe religious values, maybe others. But we're trying to translate modern science, modern applications, modern clinical techniques into a language that they understand. It's often nurses at the forefront in doing that and having that communication in a way that's digestible and meaningful to patients. And a big important point for those of us who are working in bloodless centers or in these programs, we know that the patients we take care of are often very far away from their normal days, their normal social structure, their emotional support systems and spiritual systems. So that creates a level of risk. There's an interesting article there on the bottom that talks about the role that social and emotional support play in taking in care for our patients. And again, this isn't just conjecture. There's actually real true risk and outcome negativity when patients are away from that. So all that, again, necessitates the need for compassion, and often in bloodless care and all care, nurses really embody that. A little bit about our challenges in compassionate care. Again, not specifically to bloodless, but it does all fit together. So compassionate care in the nursing literature appears as a value in nursing. It is reflected in nursing code of ethics and our standards, pardon me, in our nursing health policy guidance. But what we are seeing increasingly in the nursing literature is a lack of compassion is increasingly reported. There's a lot of reasons for that. I'm going to just touch on a couple of them in a moment. But what happens when lack of compassion shows up in our day-to-day practice? Actually, it's bad for our patients, not a surprise, right? Patients are less likely to adhere to what they need to do as we are trying to teach and deliver care, and nurses are less likely to adhere to their own standards. We lose dignity in caring for our patients. We can impede their patient rights to quality care. Patients are dissatisfied, as referred to by other speakers. We can cause unintentional or sometimes unfortunately intentional harm when we lose this compassionate aspect of our care, and again, directly, in fact, affects our patients' morbidity and mortality. And I'll just spend a moment talking about this increasing concept. And actually, this is pre-COVID. There's even more in the literature during and post-COVID, this concept of both compassion fatigue and compassion satisfaction. We won't get deeply into it, but you've heard it, I'm sure, all as practitioners discussed as an important part of how we remain resilient and continue our care in a compassionate way. But this compassion fatigue is described as this progressive and cumulative outcome of prolonged, continuous, intense contact with patients, self-utilization, and exposure to multidimensional stress, leading to compassion discomfort that exceeds endurance levels. This, again, is from the nursing literature, but I think it certainly can apply to others as well. And this state where compassionate energy is beyond restorative ability to regain it. So it affects our physical, social, emotional, spiritual, intellectual abilities in a progressive manner. So again, I think even without this academic article, we know that this is real, but there are definitely descriptions of this in the literature. This was an interesting meta-analysis of several studies that actually looked at nurses' daily practice and how their day-to-day professional lives affected their compassion, satisfaction, fatigue, and burnout using a quality of life scale. Looked at about 4,000 patients around 40 years old, most of them female, not surprisingly. Most were married, and their average years in nursing was about 13. And this was the conclusions of this meta-analysis. The long story short, again, not surprising, but this really is being studied, this concept of compassion fatigue and compassion satisfaction, that stress and negative environments promote actually this fatigue. And we can do something about that with positive reinforcement and social time with meaningful people in our lives as nurses and others too. Compassion fatigue associated with burnout, and the themes that came across actually transcribed into physical expressions from these nurses in these studies: worn out, walking on a tightrope, unbearable weight on their shoulders, alone in a crowded room, and concept of who has my back. And we often talk about increasing resiliency of ourselves as nurses and physicians and others, but there are a lot of systems issues associated with this too. And I'll just finish up with this one study which really looked at that, and I think this intersects in an interesting way with bloodless centers. So this is an article actually from the British nursing literature on compassion in nursing as a solution or stereotype. Very interesting article, but it sort of talked about the way that we describe compassion as this easy thing to say, and when people lack it or they somehow are not showing it in their practice as nursing, it's their responsibility. It's each of our responsibility to figure out how to get it back or to express compassion. Where in reality, and again, create resilience. When in reality, this approach really overlooks the need for organizations, not just individuals, to be charged with supporting compassionate care. So there's this concept that from the same article that sort of this individual focus on compassion can call out the bad apple or bad apples in the bunch of practitioners, those who are not embodying compassion or expressing that. But really, those labels on individuals are not helpful, and oftentimes it's really a systemic failure, is what this article points to. And I thought that tied really well back to the success of Bloodless Medicine. We've said it over and over again over these different years on this conference and others, that when there isn't systemic support, both of Bloodless and of PBM, these kinds of initiatives can easily fall apart, right? Both from an individual level, we're talking today about compassion, but from a structural organizational level. So it really just fits together that when we build for success in Bloodless and PBM, we need that infrastructure, that organizational structure, not all the weight of any individual program or initiative on one person. That's too much. So this patient-centered compassionate care and Bloodless, again, specifics to Bloodless, and I won't read all of these to you because you'll be hearing a lot about it over these few days, but that concept of patient autonomy, effective care, the values and preferences, collaborating with our colleagues, the emphasis on our patients' overall well-being with respect to their personal beliefs and their stories and experiences. And in the end, it isn't just nice to do, it isn't just being nice to people. Incorporating this compassionate approach actually does improve their clinical outcomes and our own professional outcomes and the way that we feel about our daily lives. So I pulled just very one high level. This is not a deeply clinical discussion, but I thought it was an interesting example from a Bloodless center of a patient. I mean, I'm not having a long discussion here about ITP versus TTP, et cetera, but it was a patient who's 28 years old. She herself is a healthcare professional. She was fatigued. She was reporting bruising. She went to her PCP. She had a low platelet count. Her PCP said, I think it's ITP, said to go see hematologist. The local hematologist got double worried. Her platelet count continued to go down, referred her to a local hospital who really had no concepts of sort of incorporating what we just talked about, her values, her preferences, and wanted to approach this in a very traditional way, not necessarily a clinically wrong way, but a traditional way with pheresis, of course, using plasma. She instead made a choice to go to the emergency department of a Bloodless center, had consultation with hematology, of course, laboratory medicine pathology involved in this multidisciplinary discussion, took into account her needs, her wishes, her preferences as a patient for whom blood was not an option. So did something a little bit different from what maybe not just traditional, but the normal clinical course, made some changes and adjusted the approach to therapy, pheresis with albumin as an example, which was acceptable to her instead of the plasma exchange, which would be typical. Again, this is not a deep clinical discussion of the management of TTP, but showed that when we really do listen to patients' preferences, there's a difference with saying, sorry, can't do it, can't take care of you, go find somewhere else, or don't get care at all, to really accommodating these wishes in a way that respects the autonomy of patients, but also delivers the best possible care we can in the environment. And here she is, looking good and happy for care. So I'm going to finish up with a little bit of a slight soapbox on the nurse's role in patient blood management and Bloodless. I get asked often, and I'm privileged to be able to speak about the role of nursing. But I think that we actually need to turn this conversation a little bit on its head as we talk about this. So we often hear, what is the role of the nurses in Bloodless and PBM? It's a kind of a limiting question, and I want us to sort of expand our minds, given the evolving and fast evolving world that we are living in this field of PBM. And again, Bloodless is connected, not all the same, but many connections. So we really don't hear that same question on many conferences that we go to. We don't hear, well, what is the physician's role in Bloodless, right? It depends on in the context we're talking about. So I think that it's sort of a limiting question to approach specifically just the nurse's role in Bloodless. The scope of practice is different from physicians. And again, the levels of responsibility in nursing are very, very variable. And you will see this in Bloodless centers as well as PBM programs. So there are nurses who work at the bedside, of course, in patient-facing roles, advanced practice nurses who work in primary care, inpatient care, administrative nurses, leadership, right? So we really need to, I think, reframe this question that we sort of keep hearing, those of us who are nurses in this. So let's stop asking the nurse's role in PBM / Bloodless. Really, what is PBM's or Bloodless's role for nurses? I know it seems like a small adjustment, but it really expands our minds and not this sort of limiting view. So while nurses have an active role in PBM and Bloodless, especially this aspect we talked about today of compassionate care and communication, the goal is not to have tunnel vision to just one type of nurse. Nurses have this wide scope of responsibility across the continuum. So nurses don't play a role in PBM. PBM / Bloodless play a role in nursing. There are specific interventions that nurses can implement. As we know, many of these programs across the world are led by nurses of varying backgrounds. This promotes that patient-nurse relationship, and very many roles in nursing in different levels of experience play a role in this. So this really big variation that's available in nursing, a very, very interesting profession, right? With all the different paths and specialties, etc., really make nurses extremely well suited to handle many avenues of PBM, including, again, not the same, but absolutely related bloodless care. So just something very quick, which is not specific to compassion, but in terms of defining the specialty, there is a subgroup of nurses working on behalf of SABM to work with the American Nurses Association, which does have lots of global tentacles, and actually creating PBM nursing as a emerging specialty, just like there are other specialties in nursing. This has really been an exciting initiative, and the American Nurses Association is pretty energetic in working with us to really define this as a specific nursing specialty. So more to come on that. I can't reveal it all now. It's not fully baked, but really some nice progress. So please keep your eye on that. So why does it really matter that we start to define this PBM/related bloodless role? It aligns with other nursing specialties. It requires a demonstration of this experience, active career activity, and knowledge base. There are career implications to this, positive recognition, of course, just personally, but in the professional setting and regulatory aspects of this, and recognizes this unique and specialized expertise of nurses who work in these roles. And again, as I said, there are global implications to that. So I'll just to finish up, thank you again for the time. If anyone on the call is a student or a resident, here's a QR code for you, a membership with no strings attached to SABM, Society for the Advancement of Patient Blood Management, is available to you at no charge. We invite you to join during the time of your studentness or your residency. So please feel free, whether you're a nursing student or a student in other specialties, please feel free to scan that QR code, or you can contact me for more information. And that is my contact information for any future questions. So thank you again for your attention and for having me here today.
Thank you very much, Sherry. We appreciate that talk very much. We have one more speaker in our morning session, or our first session of the day. So I'm happy to introduce Ilya Husny. She is, let me grab her bio here quickly, a patient advocate, a startup builder, and a social activist from Kuala Lumpur, Malaysia. She studied international business in London and began in fashion, and then also a tech startup, which focused on research and bridging artificial intelligence technologies from Europe to Southeast Asian nations. Beyond business, she has a passion for making an impact on human lives, and this has really helped her to transition to a social enterprise called Accelerate Global, which she is the chief operating officer for. And this is dedicated to addressing youth unemployment and underemployment across 6 countries. She's also trying to expand this in a national scale by being part of a founding team and the youngest female in the team of the first youth-led political party in Malaysia, which is called MUDA. She, in 2021, became a patient having her first surgery, in which she experienced an considerable blood loss. And this experience has really brought her to patient blood management and bloodless medicine, and really bringing awareness of how, as a patient, you may feel quite underinformed in making your medical choices. And after she has investigated this, she's been speaking about this issue and stigmas that surround iron or bloodless care from a patient perspective. And she'd like to raise awareness and combat stigmas surrounding these treatments that may be new or different in patients' care. And so we're very happy to have Ilya this first day of our conference, and happy to hear her talk.
Hi, thank you so much for the introduction. 1 second, with my internet, it's suddenly acting up tonight. I'll be sharing a little bit of a presentation, although it might not be as detailed as some of the speakers earlier today. So if you would just give me 1 moment to just simply share this. Let's see. All right. Okay. Hopefully this is showing. Just one moment.
One of the larger groups, National Liberation Army, has been threatening to do this for some time. This success, and they've shown them all, unity is the way forward. Tony Chen, Al Jazeera. War-weary farmers in Ukraine are serving winter crop planting.
While Ilya is
Hi.
getting her slides ready, are you ready?
I'm trying my best to see if it's starting. 1 second, yeah.
Oh, no problem. I was just going to remind everyone that slides are available at request. If you want to, please email info@bmssociety.org. They can help provide any info or background or contact with our speakers and obtaining any slides from this meeting.
Okay. All right. Well, actually, my slides are completely just like one-liners. So if it's possible, I think I'll just kickstart it, as it'll be very, very brief, and mainly focus on essentially sharing my experience as a patient. So I think thank you very, very much for a very colorful introduction just now. It seems like I have accomplished a lot, but it's really not all that. So essentially, just to kickstart things, once again, my name is Ilya. There's not that many initials after that name, as I did choose business school over medical school instead. So, which might bring the question as to why a possible capitalist is in a medical conference. So we shall get to that point in a moment. So I will give a little bit of background to myself and explain things further, and also the condition that I had, which had led to essentially an iron infusion earlier in 2021. So my life is mainly focused, I would say, in rather the business and activism and politics arena, not much so in the medical arena. So this is very much not my forte. However, I seem to find myself in medical situations very, very often. So previously, as also mentioned in my brief, I had studied in London, so I had received patient care there too. And also with like activism, that also means that I was very, very active, and some of that active career tendencies had affected my condition even further, which led to me having to sort of like, kind of stop myself and realize that I really needed to have a surgery to sort of like fix the situation. I was dealing with Shepherd's crook deformity, so I had fibrous dysplasia. I was also dealing with bone pain and so on and so forth. So I did have corrective surgery, which is essentially a corrective osteotomy. And this was in, again, 2021. That was my very, very first surgery. Prior to that, I have not had an IV line even inserted into me. So the very, very humbling experience, I would say, because for the next few days after that, it was very much having IV lines inserted and reinserted about like 10, 20 times at the very least. So that was a very interesting situation to go through. So during surgery, essentially what happened was that I faced quite a substantial amount of blood loss. So at this point, it was kind of having your HB halved. And I am a very, very petite girl. I'm not sure if that translates as much on camera, but very, very petite, 160 centimeters, like 40 kg at most. So losing that much blood in such a short amount of time took quite a bit of a toll on me. And essentially post-op, it was very, very prominent that it was affecting my condition even further and further. So I was presented with essentially not really an option, I would say. It was more so an ultimatum of saying, this is what has happened. Therefore, what we're doing in the next few hours or so is we're going to be preparing a blood transfusion for you. And I think, I'm sure many here know already the whole process of you being a patient is that you already sign all these forms prior to your surgery anyways, which is agreeing to blood transfusions, agreeing to this, agreeing to that, and so on and so forth. But there's the side effects or even the options that's available aren't really kind of like entertained, or that knowledge transfer isn't really there when you are a patient, especially more so when you are doing it for the first time. So my experience, to simplify it, was very much so, here are some papers that you have to sign. If not, we can't have surgery. So I signed it. And post-op was essentially, you have lost a lot of blood, and thus we now need to do a blood transfusion. In the simplest form, that was the interaction that happened. So
Hi, Andrea, I'm going to interrupt you just real quickly, a little cliffhanger in your story. I just want to let you know that your slides are visible. So if you want to advance or go back to the beginning.
Oh, are they?
You can see them. Yes.
Okay. Wait, let me. Does it work if I
yes.
do this?
Absolutely.
It is
Okay,
working.
all right. We'll skip this part, I think. Like, we'll go next to the next part. So this is where I'm at right now.
Perfect.
So
Thank you.
essentially, yeah. So like, I was going back to essentially what had happened. The post-op, I had lost essentially quite a lot of blood because of this. As you can see, very, very visual little insert there. So at that time, I was not really presented much with an option. It was very much so a blood transfusion is required. And at that point, kind of, it was very fast. Now, as a patient, the last thing you would want to do is care too much about the nitty-gritty. However, as a patient of, well, not really as a patient, just as me in general, I enjoyed the nitty-gritty. So once that was presented to me, I really wanted to know if that was really the only choice that was available. If that was really kind of like, the safest route, if that was really the route that, is recommended to me in all forms, or if it was simply just a simpler option. So for me personally, I had the privilege of knowing a few people who are wonderful, wonderful people who have managed to kind of share this knowledge that actually, blood transfusions aren't the only thing you do, because the common logic, and I would say this is kind of the common logic generally, especially so if you are outside the medical field, is that if you lose blood, you add blood. Kind of a simple equation, but it's never really brought to the table that, if you lose blood, you can actually just simply, kind of push your body more to create blood in the form of, let's say, just simply iron infusions. And that can actually be safer, and that can actually be a route that is more steadily for yourself. So once this option was presented to me, I wanted to try that. I wanted to try that route even further. If that was safer, if it wasn't going to be better for me, then I believe that, that should have been an option that was presented to me in the first place. But so what ended up happening was that they kind of scrapped the whole blood transfusion idea, and they went on to preparing for an iron infusion. And that was also another experience on its own, in my opinion, because I realized that as much as I was confused, or as much as I seemed to be under the light of like not really understanding the whole concept of iron infusions too much, just still knowing the basics, I realized that there are also a significant number of healthcare professionals who are in the same boat as I was. So, and this had led to a lot of arguments, a lot of gossiping gone wrong, a lot of kind of questions from nurses going, if you had taken a transfusion, you would have been healed like 5 days earlier, or you would have been healed 3 days earlier. So I was in the hospital for 10 days, which I think is too long for anyone. And this is the end of year 2, so it was even worse because of that, since I wanted to watch fireworks for New Year's and so on and so forth, for like Christmas and all of that. But that didn't happen because of the blood loss, essentially. So while they were preparing the iron, due to the misinformation that was available, I kept getting conflicting informations from various parties. So from my doctors, I was hearing different things. From the nurses that were taking care of me, I was hearing different things. From the housemen who were also taking care of me, I was hearing a whole nother different thing. So it was very hard as a patient to identify and actually realize which information is correct and which information is applicable to my situation. So in preparing my iron infusion, what had happened was they genuinely wasted quite a little bit of processes, time, and also just resources, because the first time that they tried to do an iron infusion on me, it was essentially kind of a failed attempt, because I had a slight fever that was going in and out. And I think it wasn't too, I would say, significantly concerning to me, as I was still eating properly. I was still, rather quite hydrated properly. I didn't have loss of appetite or anything like that. But because I had a slight fever, they flagged it as I'm not fit to have the iron infusion at that moment. So even though it was already prepared for, everything was essentially set in stone, IV line was ready, just got flushed and everything. But they wasted a whole bag of iron, and it would have been a successful iron infusion simply because I had a slight fever raise. And I think that really highlights that, misinformation can not only reduce the confidence of patients, but it can also lead to even resources being wasted even further in a situation like this. And this is only as a one-time instances that was actually recorded. So if you scale this to the amount of times where iron infusion attempts are being made, even a slight percentage of failure in this degree, where it's something as simple as an increase in fever, to still waste the whole bag, it's still something that is simply, it doesn't justify the cause. So that was my personal opinion of it. So after that, they did do a successful transfusion later, not transfusion, sorry, iron kind of like infusion and so on and so forth. And I ended up improving quite, I wouldn't say extremely fast in the first few days, but I definitely felt a lot better. I would imagine a lot more better than if I had a transfusion. So once I was actually discharged, after having my last infusion, my HB at that time had doubled. So now it stands at 15, which I would say is pretty good. But at the same time, it's the fact that to get to that point, there were so much hurdles. There were so many hurdles with healthcare professionals. There were so many hurdles with, understanding the stigmas. There were so many limited information that was being made available, simply because it wasn't even presented at the very start. Just to backtrack a little bit, at the very start, it wasn't even presented as an option, unless prompted, unless I had pre-existing information or so on and so forth. But how many times does it happen where patients have this information beforehand? How many times does it happen where patients are aware or even feel secure enough to be like, hi, is this an option, or is this something that I can do, if they are not being told it from the start, if they are not even given it's kind of more of an ultimatum that transfusion is the way to go, and this is the way that we're going to do it, and that's final. So I think it brings forth like the importance of the topic of everything, which is bringing compassion and human touch to the cat. At the end of the day, the medical industry exists for patients, and I think at the core of that, it is very important that at the end of the day, if you are handling any patient care in general, that options are constantly provided for, and knowledge is actually more unified and delivered. And I think having fractions when you're having delivery of medical information is something that truly reduces a patient's confidence in already a stressful situation. I think that's something very important to kind of be aware of, because I know for a fact, from personal experiences and from engaging with a lot of groups, and also even from my NGO experiences, whereas if you are sick, options are not something that you have many of. And when it's being restricted even further in instances where misinformation are being laid out, or instances where healthcare professionals are not informed accordingly to deliver this information, it kind of brings down that confidence even further and further and further. When I'm sure many here already know, when there are so many benefits to iron infusions, from not just a direct patient care standpoint, from economic standpoint, from a social standpoint, and so on and so forth. So I think that is something that really needs to be highlighted from both ends, from the end of a healthcare industry, and also from the end of a patient. And I think that is one experience I would like to share from my end. So Hopefully it wasn't too laggy.
Thank you very much, Ilya, for sharing with us. We now have some time for questions and discussion for our panel. You
Yes.
can raise your hand in Epic at the bottom there. There were a few questions that have already been addressed in the question and answer tab. I know one theme or a couple questions that were volleyed back and forth were regarding billing and revenue for bloodless medicine consults. Dr. Waters did address that in the chat, but I didn't know if anyone else from the panel had any questions or comments about that. I know from our experience at our institution, we do have bloodless medicine consults that we do bill for. They're largely addressing the treatment with iron preoperatively or in our peripartum patients. I had a question for the panel. As we're discussing compassion in our medical care, from my own experience, this is something that's certainly addressed in medical school training. But I think especially some of these issues of patient autonomy and bloodless medicine care may be something that isn't focused on as much. And especially as the landscape is changing in medical practice. I had a curious question to see if anybody from the panel could address how you think we could be doing better in training of nurses and physicians and medical care workers, how we could influence the education that providers receive before they go into practice.
I mean, so Erin, I can start to try to answer. Again, I'm not a physician, but certainly have a lot of time around nurses and certainly young physicians. I'm not a medical resident. I have watched, of course, interacting with lots of hospitals, lots of residents' efforts, at least during residency. I can't necessarily speak to medical school. Probably John or others who are more deeply involved in that part of it could. I do feel like the ACGME, at least in the States, has built some of the structure in residency to try to address these more human aspects. It's complex, right, to get a person through X years of residency and maybe fellowship that follows. But I think, I've seen a lot of institutions try to meet some of those requirements in their graduate medical education experience, sometimes with outside consultants, sometimes with residents participating on patient advisory family councils, things like that, right? And so there's an attempt to bring the patient voice, and that's in the effort. Lots of reasons to do that, right? Amongst them, helping us develop that empathy and compassion for their real experience. But I think having, and again, that's more to residency than your question specifically to medical or nursing school. But I think at least I'm observing that during both nurse residency and physician residency, some active discussion. At least that seems to me different from early on in my career, where you hoped that people sort of learned along the way, but really specific carved out time for them to, serve on various groups or interact directly with patients and families. With the intention of developing and honing those compassion and communication skills, not just the clinical ones. I think I see some progress, at least in the States, in that regard.
Thank you.
Yeah, this is a tough nut to crack. I think, there's so much burnout in the United States I don't know about the rest of the world, but I think that's probably similar in much of Western Europe, that the burnout is somewhat reflective of how people are being treated in their facilities, in their hospitals. I mean, we've become cogs in a wheel, or rather a machine, that are considered irreplaceable. And the compassion, I think, comes from happiness on the part of the providers. If they're happy with their job, they're going to be compassionate to the patients. If we're not treated well, by our health systems, then it's going to be very difficult to generate the compassion for our patients. So we really need to stop abusing healthcare providers. I'm not sure there's a good answer for how we do that. RA there always has wisdom that he can impart.
So unfortunately, I had to step aside for a minute. I didn't hear the question, if there was one.
We were talking about the role of kind of adjusting our medical education as we're preparing for careers in medicine to focus a bit more on compassion and more collaborative care with our patients, instead of sort of the old school way of doctors telling patients how it is and what we say should go.
Yeah. Thank you. Thank you, Aaron, for restating it. Paternalism is has been shown the door many times in medicine. And unfortunately, the door's not closed behind paternalism. It's still in the room to some extent. I think, though, that we have seen a couple of things that happen. One is that we were unfortunate to be a generation or multi-generation that was exposed to a pandemic, something that most people in healthcare before never experienced, and we're hoping that they won't after us. But that's probably not going to be the case. And what that's done is, I think it's changed the face of medicine. As a matter of fact, what we're contending with right now, and I'm sure this is not limited to the United States, is a rise in violence in healthcare institutions coming from patients towards healthcare providers, specifically emergency room physicians and nurses, and as well as other staff. So there are a lot of elements that are barriers to compassion. And one, of course, is on our side, meaning the healthcare side. I've never been a fan, if you will, of medical education as being a source of a changing behavior. I think that that happens, I think, in residencies, interns and internship residencies. So I think that that's where the emphasis on this has to be done. I think most people who go into medicine start off with the ideology that they're going to help humanity. And throughout the course, I think they find that there are barriers for that. In addition, that there may be other different incentives. So that may be the change during medical school or early training. But I think that when they come into the real world, which is internship and residency and thereafter, that this should be really a measured skill that has to be addressed continuously, not just once in the training. I think listening to both Sherry and John, I think one of the big issues we run into is that there is enormous amount of pressure on the healthcare providers. We're asked to give compassion to patients, but yet and yet at the same time, we're not always structured to do the same thing in terms of support for the healthcare providers. So I think the awareness, increasing awareness that we need enormous amount of support in addition to education when we start facing patients as providers, meaning after medical school or nursing school or any other healthcare professional school where you're interfacing with patients. We need to create those supports for and I think that John sort of alluded to that as the happy clinician. I think it probably puts it in context that it's a supported clinician. In addition to that, I think we really need to look for supportive services that constantly check on each individual healthcare providers, regardless of what profession or license they carry, in terms of their level of stress and level of pressure to be compassionate, but at the same time, also understanding that they need the support to be able to do that, meaning they need the compassion also coming from the institution. So to make it long or longer, I would just add that, and I think Sherry alluded to it also, and I tried to in my presentation, you need to have this pervasive throughout the organization. It cannot just be individual clinicians or teachers or whatever it is. It's got to be a cultural change, just like we're looking for culture change when we're looking at bloodless medicine and surgery, when we're looking at patient blood management. So I don't know if that answers it. I know it was a little long-winded, but that's the way I am.
Thank you. I see that Professor Ilori has her hand raised. Would you like to unmute and ask your question?
Well, I wasn't trying to ask a question. I wanted to add to the issue of billing for bloodless medicine and surgery. Here in Calabar, when we get a consultation for bloodless medicine, we don't bill anything because the patients pay bill to the hospital. So every consultation the patient has within the hospital is put into that bill. So there's no specific billing for consultation with medicine, bloodless medicine and surgery. For the introducing the curriculum, I think I'll go with Shander that it's just a cultural change. It's not very easy because, like, for now in Nigeria, the government is having a unified curriculum for all university programs. So to introduce it, you have to go through the Nigerian University, Commission to introduce it to all the medical schools, and they have just reviewed the curriculum. However, here in Calabar, with the surgical, in the surgery department, a session or a lecture, maybe 2 or 3 is given to patient blood management. So that is the only way we can introduce the patients or the students to the bloodless medicine and surgery. And through sometimes, most of the time when we have our national, the yearly bloodless education week, we bring in medical students, bring in nursing students to have sort of a novelty march. And from there, we introduce them to bloodless medicine and surgery. I think it's more of a cultural change rather than introducing it to into the curriculum. Because if all doctors are aware, part of our oath taking is to be empathize or to show empathy, compassionate to patient. But as Rashida has there, because of stress of work in Nigeria here, a lot of physicians and nurses have left the country. So the few that are left are being overworked, and government is not making any effort to replace those ones that have left. So it's quite stressful for those working here now. So it's more of a culture, and to be able to show compassion, you have to be a little bit relaxed. You have to enjoy what you are doing before you're able to show compassion. But when you're under stress, you become a little bit irritable. And it's difficult to really show compassion of patient, or like, for example, come and say patient doesn't need blood. They just said, they push the patient aside. I said, when you're ready, we'll attend to you, because they're already under pressure. So it's really need a cultural change to be able to implement those things rather than changing the curriculum. If individual doctors, as we continue, a lot of people have started imbibing the idea of this bloodless medicine throughout the year by year, as we are holding these conferences, a lot of people are joining and they are imbibing the culture of bloodless medicine and such. I think we are achieving something rather than putting it in the curriculum. Most times, medical students don't pay attention to those things. It's when they come out and maybe keep on bringing it up, education like this, then they'll be able to say, let us think about it and change the way we practice. Thank you very much.
Thank you. Dr. Sather, I see that your hand is raised as well.
Yeah, can you hear me?
Yes.
Yeah, no, I was just saying to make that change, the cultural change. Yes, it's a tough one, but I think we just have to persevere and continue with educating everyone, the public, the doctors, the nurses, everyone. It's going to be a tough journey, but yeah, we should not give up. And I'm getting a lot of calls from actually the public, telling me that they don't want blood because they've heard about, we've gone on YouTube, we've educated on the radio. Yeah. And so I'm getting, the awareness is there. So hopefully we can make that change.
Thank you. Dr. Inyama, I see your hand raised.
Yes, thank you. I thank this year's organizers for this topic and the wonderful contributions by the speakers. Professor Arias Shander's talk is particularly insightful. My observation is like he showed anatomy of the brain and the neuroanatomy involved in having empathy and things like that. But what about the heart? I think having compassion, the heart is involved. That is the figurative seat of our emotions that helps us to make decisions. How do we teach people how to adjust their heart condition to be empathetic? Because the idea is that you can teach someone to be empathetic. What role does the heart play in this? Is it possible? Because some people, in my own opinion, maybe I may be wrong, you cannot train them to be sympathetic or empathetic. And yet they have found themselves in the medical school. How do you change such people? Some people enter into the healthcare space not because they are sympathetic or care for those who are suffering or those who are sick, but maybe for the prestige. Can you change such a person if he's confronted with a patient who does not want blood or a situation where he should use blood less? So we may have to expand the concept of even the training to how do you reach the heart of the physician or the doctor so that he can, whether someone is there or not, let it emanate from the innermost seat of his emotion to be helpful and not to be trained to be helpful. However, if there's a curriculum, I do not know. It needs to be tested and validated. But what Professor Laurie said, maybe this forum that's being used now with convince adopt the bloodless medicine surgery. Hopefully, as they do so, maybe compassion will come into it. But the curriculum is something I really want to see how it's going to work. Thank you.
Thank you.
So
oh, go ahead.
No, I was going to say that, I think that we can't leave the message that we can't train compassion. I think that there is a way of training compassion, but I think that we have to also understand some of the differences that we're looking for. It's not just, as we said, putting your feet in someone else's shoes. The part of training in terms of compassion is to be able to recognize your own limitations when you're trying to care for another individual. As an example, if I am so entrenched in transfusion is the only way I can treat you, I need to recognize that that is a shortcoming for a patient for whom blood is not an option. And I need to recognize that I need to transfer the care to someone else who will be able to help that patient. So training is not just necessary in being, as you said, from the heart and something that's innate. The training has multiple levels, including going back to your duty as a clinician. And our duty to patients goes beyond where they're coming from and who they are. The duty, for example, of a physician who is caring for people in the battlefield, although unfortunately this goes back to the whole issue of violence, they need to care for the injured who are their own in the same way that they take care, in the same way they need to take care of the injured who are of the enemy, who are there for care. So these are things which create enormous amount of emotion amongst us, the clinicians, and we need tools to be able to manage them, including the transfer of care if we cannot manage the situation. So there are elements that are very important in terms of recognition, of what you're capable of doing, but also trying to recognize what it is that you can't. As you're trying to maybe expand your horizons in terms of compassion, to your point before, in the meantime, the care of the patient needs to be addressed in the best ethical fashion that we can.
Thank you, Dr. Shander. There is one question in the queue, if any of the panelists may be able to address that. We are ready to move on to the next session. I see Dr. Nesargiker's hand up, as well as Dr. Yap. Those are the two next moderators for the abstract presentation. So I'll turn moderating over to you.
Thanks, Erin. I think just a final comment before the discussion closes. So when we're discussing about the topic about bloodless medicine, so I think I always highlight, so I got trained from India, then I've spent the rest of my life in UK, and now I moved back. So as in India, there's not a single your teaching program or education highlighting about bloodless medicine. It's only when we went to UK, I heard about Jehovah's Witness. And that is when bloodless medicine came into discussion process. Even in UK at the moment, the discussion about bloodless medicine only comes when this Jehovah's Witness comes into the picture. So what we are trying to cyclically to change is the perspective of people to move away from a religious perspective to a clinical perspective where there is good evidence to show that bloodless medicine is a safe practice. When you show evidence, then compassion follows, because now you're confident in your delivery of what practice you're driving. So just saying, it's still very interesting because none of our medical books talks about bloodless medicine as an alternative, as a safe practice. So that's something to highlight as we go along. As you see the panel today, from participants, we are from America to Australia, Malaysia, all across continents. And then we have our own medical education systems, the practice, which is slightly different. So I think one of the platforms we should keep using this is to highlight more about clinical evidence, which is supportive, rather than just making it as a Jehovah's Witness. That's my personal view, because we in India have a very low volume of Jehovah's Witness. But I practice bloodless medicine in my cancer surgery. It goes fine. But only when you start highlighting it as a clinical evidence, I think we'll go to the next level up. And maybe we can change the way people think and how the medical education topic is discussed. Just my personal opinion only.
Perfect. We agree.
Push the fact that this is superior care, and then advocacy can be added to. And I want to say that teaching is important. It's not just trying to change attitudes. So we have to didactically teach, we have to give IV iron, how to carry out bloodless surgery, and so on and so forth.
So Mandy, are we ready to start the next session?
Yes. I'm just waiting for everyone. Thank you for everyone. We are coming to the oral presentations. So first of all, I'll introduce myself. I'm Mandy Yap, one of the clinical hematologists who was being trained by Dr. Jamila from Malaysia. So today we're going to have 4 presenters for our oral abstracts. So thanks, Nathaniel, for giving me this opportunity. I will introduce my co-moderator as well, which is Dr. Prabhu Nesarkigar, the MD FRCS, a consultant upper GI cancer, bariatric and advanced endoscopy surgeon, HCG Hospital, Bangalore, India. Am I correct?
Yep.
Dr. Nesarkigar. Yeah, so my another co-moderator will be Prof. Ngim Ngim, who is a professor of orthopedic surgeon from Provost of the College of Medical Sciences of University of Calabar of Nigeria. So I'll welcome the first presenter, who is Dr. Ifia Kandu, Iber Oji Ludu, I hope I pronounce it correctly, yeah? The Senior Registrar of Plastic and Reconstructive Surgery Unit from Surgery Department of Federal University Teaching Hospital, Owerri, Nigeria. He'll be talking about the bloodless surgery of a recurrent left arm tumor in a 63-year-old female Jehovah's Witness, a case report. The floor over to you. Thank you. Is Dr. Oji Ludu is there? Is Dr. Oji Ludu there?
He's actually here.
Yeah, it's online, I think.
Yeah. Because I can't see his slides. Oh.
Okay, maybe we can take the next one.
But is Dr. Goodwin online as well?
Yes.
Okay. So I think so Mandy, I'll just take one, introduce the second speaker until the first speaker comes back. So pleasure introducing the next speaker, Dr. There he is. So you're Dr. Mori Goodwin? Hello? Okay. So Dr. Mori Goodwin is a consultant obstetrician gynecologist at Air Force Hospital in Ikeja, Lagos, Nigeria. He's going to be talking about the hemostatic techniques adopted during myomectomy to prevent the use of allogenic blood transfusion in low resource setting. Dr. Goodwin, over to you for the presentation, please. Thank you.
Thank you very much for the introduction. Let me share my slide, please. Okay, thank you very much. Good afternoon, everybody. I'll be discussing a case report on hemostatic technique adopted during myomectomy to prevent the use of allogenic blood transfusion in low resource setting. I have no disclosure. Let me start by saying that myomectomy as a surgery has an inherent risk of hemorrhage. Sometimes it could be life-threatening, thus necessitating the use of allogenic blood transfusion with its resultant adverse outcome. However, the purpose of this discussion will be aimed at demonstrating that with effective hemostatic technique, myomectomy can be conducted with minimal loss of blood loss, thus preventing the use of allogenic blood transfusion. To this end, I'm going to present a case summary of Mrs. OK, a 35-year-old para 0+1, who presented with complaint of abdominal swelling of 2 years duration and recurrent abdominal pain of 3 months duration. The abdominal swelling had progressively increased in size, initially localized at the pelvic region, until it was above the umbilical region. There was abdominal discomfort and pain, which became severe in the last 3 months prior to presentation, that necessitated seeking medical care. There was also waist pain and distortion of our gait. There was no history of menorrhagia, dysmenorrhea, dyspareunia. There was no history of early satiety or family or personal history of breast, ovarian, endometrial, or colorectal CA. There was no urinary symptoms, constipation, leg swelling, or weight loss. She attained menarche at the age of 12 and menstruated for 5 days in a 28-day menstrual cycle. Her last menstrual period was 14th of December 2022. She was aware of modern method of contraception and had used emergency contraception in the past. She had an incomplete abortion 6 months prior to presentation after 10 weeks of confirmed cirrhosis. The abortion was completed using medical therapy and there was no post-abortal sequelae. The past medical history was not remarkable. There was no history of blood transfusion or surgery. There was a family history of diabetes mellitus, the father, but no history of hypertension. Review of system was not contributory. On clinical examination, we met a young woman who was pale, anecteric, febrile, not dehydrated, with no pedal edema. Breasts were bilateral symmetrical and with no palpable masses. Our respiratory rate was 18 cycles per minute. The lung fields were clinically clear with good air entry bilaterally. Our pulse rate was 84 beats per minute, which was regular and of good volume. The blood pressure was 120 over 80 millimeter mercury. The abdomen was full and moved to respiration. There was no area of tenderness. The liver and the spleen were not properly enlarged. The kidneys were not palatable. However, there was an abdominopelvic mass which was 32 weeks size gestation, uterine size gestation, which was firm in consistency with irregular margin, was fully mobile, fully mobile in both planes. It was not attached to the overlying skin. There was no demonstrable ascites. On digital vaginal examination, the vulva and vagina were normal. The cervix was healthy looking. The pelvic mass was continuous with the uterus as it moves with the cervix. There was no anesthesia masses or tenderness. The pouch of Douglas was free. So an assessment of a huge symptomatic uterine fibroid in a 35-year-old para0 + 1 with anemia was made. She was asked to conduct some investigations, and the result of the investigation is as seen on the screen. Of significance was a reduced hemoglobin level of 8.7 grams per dl. Other parameters were clinically normal. Ultrasound scan result revealed an enlarged uterus with multiple uterine fibroid, which was intramural, occupying the entirety of the fundus, the anterior and the posterior wall. Both ovaries and the pouch of Douglas were partially obliterated by the uterine bulk, and there was no free pelvic collection, and there was no back pressure effect on the kidney. The management plan was explained to the patient, and she was canceled on myomectomy. The need to optimize her blood with hematinics was emphasized to her, and she consented to it. However, after a month of oral hematinics, there was marginal increase in the hemoglobin level, as the hemoglobin level was just 9 grams per dl. So the patient was placed on parenteral iron sucrose, erythropoietin, parenteral vitamin C, B12. Hemoglobin level was optimized to 11 grams per dl within 2 weeks. She was admitted for surgery on the 26th of April 2023. Investigation were confirmed. Informed consent was obtained from her, and surgery took place the following day. She had a myomectomy and dye test on 27th of April 2023. The picture here shows the uterus after externalization of the uterus. The clinical findings were that the pelvis was clean, and you could see a uterine size of about 32 weeks. The fibroid mass, there were 3 major fibroid nodules. The large fibroid mass was occupied in the fundus, the posterofundal region of the uterus, and which measured about 18 by 16 centimeter, and the other smaller nodules were occupied on the anterior and the posterior wall, which were about 4 by 2, 4 by 4 centimeter, respectively. The tubes and ovary, as can be seen there, was grossly healthy looking. She had a dye test, so we tried to actually see whether the tubes were patent. So a dye test was conducted, and we're inspecting for the spillage of the methylene blue. We could see that the methylene blue was, one of the tubes was stained with the methylene blue. In fact, it was a positive dye test because there was spillage on both tubes. This next picture shows the uterus after the myoma has been enucleated. And I also want us to take note of the hemostatic techniques used there, the pericervical tourniquet, which was applied at the isthmus there. We see that the surgical field is quite dry because of this hemostatic technique that was used here. And this is myoma, one of the myoma specimens that measured about 18 by 16 centimeter. And this is the uterus after it has been repaired. We could also see the hemostatic suture there, and there's no bleeding because of this hemostatic technique that was used here. And also look at the uterus, though it cannot be felt, but it looks very toned because of other hemostatic agents like the misoprostol that was passed rectally and started acting on the uterus, making it to be contracting. The woman had an estimated blood loss of 300 mils. The postoperative care was quite satisfactory as she recovered satisfactorily. The vital signs were stable, and she had intravenous fluid, antibiotics, and analgesics for 48 hours. The urethral catheter was removed after 24 hours. The post-op hematocrit was done on postoperative day 2, which was 9.3 gram per DL. The abdominal wound was inspected on day 3 after surgery. The wound edges were clean and well approached. She was discharged on postoperative day 5. The study report shows that the microscopy and the microscopy findings were in keeping with that of uterine fibroid with hyaline degeneration. There was no evidence of malignancy or adenomyosis. The follow-up was equally quite satisfactory. The patient had recovered fully well. Her menses had resumed and flowed regularly. The presenting symptom had abated completely. Thus, the patient was discharged out of the gynae care. Myomectomy traditionally has an inherent risk of intraoperative bleeding because of the increased vascularity of the fibroid uterus. The fibroid itself may predispose the patient to present with anemia, thus requiring the need for optimization before surgery. Such was the case with our index patient. She had anemia before surgery and thus she was optimized. Preoperatively, she was given parenteral iron, erythropoietin, vitamin C, and B12, which actually optimize that. These measures have been shown to facilitate erythropoiesis in cases of poor tolerance of oral hematinics, poor compliance, and impaired red blood cell production. This was the case with our patient. She had a poor compliance and also poor tolerance of these hematinics. And that necessitated our use of this parenteral hematinics that actually improved their condition. We look at a study presented by Renew et al. On blood management, patient blood management. You recommended that patients who have a hemoglobin level less than 13 grams per DL should be commenced on erythropoietin therapy 1 month before surgery. A patient had far less than that, and so she was commenced on this, and she did remarkably well. A randomized clinical trial of preoperative oral iron versus intravenous iron on anemic patients, Killer et al. Concluded that intravenous iron was better than oral iron in treating preoperative anemia and iron deficiency. We found this to be true because our patient, following the administration of intravenous iron, she made tremendous improvement in terms of the hemoglobin level. Another hemostatic agent we use commonly in my center is misoprostol. It's a synthetic prostaglandin E1 analog, which will pass rectally 1 hour before the myomectomy, and it causes reduces blood loss by causing uterine contraction and reduce of uterine blood flow. However, the onset of action as well as the duration of action depends on the route of administration. Like I'm seeing here, different route of administration with different onset of action and duration of action. We actually prefer the rectal route because even though it has a slow onset of action, but it has a long and sustaining effect on the uterus, as can be seen during the myomectomy we just we exhibited earlier on. We have tranexamic acid, which is another hemostatic agent we use. It is an anti-inflammatory agent. It acts by blocking the lysine binding site, thereby inhibiting fibrinolysis. In other words, it prevents the dissolution of the clots, thus prevents or helps in reducing capillary blood bleeding. It has been used for ages, and it has been found to reduce blood loss and need for blood transfusion. We normally give this drug at induction of anesthesia. Our patient benefited from this measure as well. Intraoperatively, techniques such as the use of pericervical tourniquet have been found to significantly reduce blood loss during myomectomy. We saw it during the earlier slides. The tourniquet is applied at the isthmus to actually occlude the uterine artery, and it is believed that it is based on the principle that the major supply of blood to the uterus is the uterine artery. So if one is occluded, it reduces blood supply to the surgical field and makes the surgical field clear for surgery. Ikechebelo et al. In his work titled "The Use of Tourniquet to Reduce Blood Loss in Myomectomy" substantiated to this fact as well, that tourniquet, when applied pericervically, can also help in reducing blood loss during myomectomy. However, some authors feel that the temporary occlusion of the uterine artery does not significantly reduce blood loss. From our own experience, we come to acknowledge the fact that proper application of pericervical tourniquet gives the surgeon a bloodless surgical field that we could see in that during that surgery we demonstrated. And when it is further complemented with other hemostatic agents, you have a complete bloodless surgical field for operation. And if at all there's bleeding during the surgery, it's very, very minimal that may not necessitate use of allogenic blood transfusion. Other intraoperative techniques of reducing blood loss include the use of intramyometral vasopressin and parenteral ascorbic acid. These have been demonstrated in other centers as one of the techniques for reducing blood loss. Of course, they are quite effective, particularly the intramyometral vasopressin. However, we have to exercise caution when using this drug, because if it is inadvertently injected into the vessel, the vasopressin, it may cause some cardiovascular problems such as bradycardia and elevated blood pressure. The ascorbic acid is actually effective too in reducing blood loss. However, the drawback in it is that it is water soluble and is not stored in the body. Thus, once it's depleted in the system, there could be emergence of bleeding. Surgical dissection techniques such as the use of electrocautery helps in decreased blood loss. We use this routinely in our center, diatomy. It is quite effective because, one, as you are cutting, you're also securing hemostasis. The only drawback is that it causes excessive scarring and poor wound healing. However, in an experienced hand, discover that the advantages far outweigh the disadvantages. Kane et al. Randomized 100 women requiring mid-laparotomy to either diatomy. They also found that diatomy incision was agreed totally with this. We agree totally with this report. We agree totally with this report because we widely use this measure in our practice, and we also have good result that is comparable to what Kane et al. Discussed here. Above all, I want to say that performing myomectomy during follicular phase of menstrual cycle is generally considered the safest, because myomectomy is actually structured toward the follicular phase because there's significant reduction of blood loss. And this is based on the fact that during the follicular phase, the pelvic tissues are less congested and less engorged, even though some studies have shown that they can also conduct myomectomy in other phases. But we look at the physiology of the follicular phase, discover that this seems to be the ideal period for conducting myomectomy. Thus, it underscored the importance of taking a thorough menstrual history during preparation of the patient for surgery, so that the surgery is conducted during the myomectomy, during the follicular phase. So I want to conclude by saying that a bloodless myomectomy is attainable, even though there is an inherent risk of hemorrhage. However, with good knowledge and skills in application of the appropriate hemostatic technique, it will help not only to minimize blood loss during surgery, but also help to avoid the use of allogenic blood transfusion and their adverse outcome. Indeed, we can truly demonstrate compassion at the heart of bloodless medicine if we strive to adopt these measures of this blood conservative technique during our surgery. Thank you very much for listening.
Thank you, Dr. Monday. That is a very good presentation demonstrating a good use of both pre intra and post-operative care. A couple of questions I had. One is, do you have a team when you have a patient who comes for bloodless medicine surgery? Do you have a hematologist or a physician? You have an MDT discussion to formulate what drugs need to be given preoperatively? Because I know you showed erythropoietin, iron, vitamin C, and B12. So do you have a team which discusses this and prescribes to the patient?
Yes. Yeah, we have some team that we're trying to recruit. For example, the anesthetists routinely, they use tranexamic acid for most of our surgical patients because they have realized the hemostatic effect in it. And my team as well, too, for patients coming from myomectomy, routinely we prescribe misoprostol for them so that can be passed rectally 1 hour before the surgery. And like I said, the diatemy is a routine instrument in our facility.
Okay. That's good. So as I said, you're clearly demonstrating that if you work well as a team, you have good outcomes. I'm just seeing if there's any online questions as such. There's a question by one of the delegates saying, when is the best moment for a myomectomy? So if you have a patient who comes in with this thing and you're planning a bloodless surgery, when would you time the patient from seeing in the OPD to possibly on the surgical table?
But I can't, please, pardon, I can't hear you very well.
So one of the questions is, when is the best moment for a myomectomy? So I think what they mean is, if you get a patient for a myomectomy in a bloodless medicine scenario, how long would you wait from seeing in the OPD to taking them to surgery?
Okay. Like I said, the best period is the follicular phase. So if we see a patient with a symptomatic uterine fibroid, we try to optimize the patient, stop the bleeding. We have other hemostatic agent we can use to arrest the bleeding, particularly for those patients that have menorrhagia, arrest the bleeding, and then try to build up the blood to a reasonable level before we go in.
Okay. Okay, that's good. Thank you very much, Dr. Mande. I think I'll just pass it on to Prof. Ngim to introduce the next speaker, please. Thank you, Dr. Mande.
Thank you very much.
Thank you very much, Dr. Nesagika. The next presentation is by Dr. Oluwatomi Odutola Oyewo, a consultant urologist working at General Hospital Ikorodu in Lagos, Nigeria. He'll be speaking on the topic, the management of severe anemia in metastatic prostate cancer, a case report on the use of erythropoietin, iron therapy, and adjunctive care. Dr. Oyewo, if you're online, over to you, please. Dr. Oyewo?
I think you're muted, Dr. Oyewo.
We can't hear Dr. Oyewo. Can the host please unmute her? Can anybody hear Dr. Oyewo? I can't hear her.
No, cannot hear.
Dr. Osoro, can you please unmute Dr. Oyewo?
Let me see how possible. I have people who are...
Unmuted her. She can speak, I think, now.
See her screen.
We can
It's
see
unmuted
our
now.
screen, but the audio is off.
I'm thinking we should just give her time to sort it out while we listen to Vishnu.
Okay. Mandy, over to you then.
Thank you, Prof. Thank you, and Dr. Nesakigar as well. So I'm going to introduce the fourth presenter of the day, which is Dr. Vishnu Prashad, who is a fellow in hematology from Malaysia. He's going to talk about a bloodless management of breakthrough hemolysis in a patient with paroxysmal nocturnal hemoglobinuria. Dr. Vishnu Prashad, over to you.
Hi, good evening. I'll just share my screen. Thank you, Dr. Mandy, for the very kind introduction. And a very good evening to all our fellow panelists. All right, so I'm Dr. Vishnu from Malaysia. I'll be presenting on a case of paroxysmal nocturnal hemoglobinuria, which was managed without blood transfusion. So I have no disclosure. So basically, just a bit of introduction about paroxysmal nocturnal hemoglobinuria. It is a very rare condition, and it is caused by a mutation, usually a somatic mutation in the PIGA gene. So basically, it results in an acquired clonal hematopoietic stem cell disorder. So I will explain a bit more about what happens in PNH. But PNH is basically characterized by the classical triad of hemolysis, which may be intravascular or extravascular, thrombosis, as well as bone marrow dysfunction. And in PNH, the hemolysis is typically complement mediated. However, the name is sort of a misnomer because it is not truly paroxysmal, it is not truly nocturnal, and patients do not always have hemoglobinuria. So in general, patients tend to have a chronic background hemolysis going on. Yeah. So the diagnosis is usually made via flow cytometry. So this is just a short diagram, a brief diagram to explain what happens in PNH. So basically, the genetic mutation that happens in PNH codes for these GPI anchor proteins. So these proteins are very important to hold these cell markers. Hold on, yeah, I'll just use. So the anchor proteins are important to hold the cell markers such as CD55 and CD59 on the surface of the red blood cell. And why are these markers important? Because they help to protect the red blood cell from complement-mediated hemolysis. So when you do not have enough of these GPI anchors, you do not have these cell markers on the surface of your blood cells. So what happens is that it makes your blood cells more susceptible towards complement-mediated hemolysis. So basically what happens is that without your CD55, it enables the formation of the membrane attack complex, which will then lead to intravascular hemolysis. And without your CD59, it enables the complement to coat the surface of the cell, and then the cell is then taken away to the spleen and undergo extravascular hemolysis. So basically, because of the hemolysis, patients tend to present with severe anemia symptoms. They can have hemoglobinuria, but not always. They can present with thrombosis. It is very classical thrombosis in PNH, and the thrombosis may be arterial, may be venous thrombosis. And it's very common to have thrombosis in unusual sites in PNH as well. And another classical symptom in PNH is smooth muscle dystonia, where they can present with abdominal pain, dysphagia, and erectile dysfunction. I will explain in the following slide why this happened. And of course, in PNH related to bone marrow disorders and all, you can also have pancytopenia as well. And classically in PNH, they tend to have iron deficiency. This is because of the loss of hemoglobin in the due to the hemoglobinuria. So that causes a lack of iron in the patient. So basically, because of the uncontrolled complement activation that is happening in the body, so this leads to a whole lot of consequences which can be severe for the patient, which can lead to mortality and morbidity. So thrombosis used to be the commonest cause of mortality in patients with PNH. Okay, so and here is just to explain a little about what happens. So when there is release of free hemoglobin due to intravascular hemolysis, this free hemoglobin binds to the nitric oxide in the blood. So nitric oxide plays a very important role in vasodilation as well as smooth muscle relaxation. So when the free hemoglobin binds to the nitric oxide and mops up all the nitric oxide in your blood, so basically there is not enough nitric oxide to carry out its function. So that leads to all the smooth muscle dysfunction that happens. So on the background of chronic hemolysis, PNH patients can have an acute severe hemolysis that may be precipitated by anything that increases complement activation. So this can be infection, this can be surgery, basically anything that causes added stress to the body. This can cause increased complement activation and acute hemolysis in this group of patients. So we come to my case. So she is a young 26-year-old lady who works as a nurse at a private hospital in Malaysia. And she was diagnosed with PNH back in 2018. And she is currently enrolled in a clinical trial for a complement inhibitor. So these complement inhibitors have sort of revolutionized the prognosis of patients with PNH. So she's enrolled in a clinical trial because the medications are very expensive and not readily available in Malaysia. So she had a last episode of breakthrough hemolysis in April, which was precipitated by COVID-19 infection. So at that time, she presented with a hemoglobin of 6.1 and she was transfused 2 pint fat cells. So this time, she presented with anemic symptoms of worsening lethargy, pre-syncopal attack, palpitations, and chest discomfort, as well as vomiting and poor appetite, however, denied any fever or infective symptoms. On examination, she was pale and lethargic looking. Her BP was normal, but she was tachycardic. And examination was otherwise unremarkable. So her full blood count showed severe anemia with a hemoglobin of 3.6, with indirect hyperbilirubinemia and a markedly elevated lactate dehydrogenase of more than 4,000. So basically what was given to her in the ward, so she was started on some hydration in view of the acute hemolysis going on. She was given supplemental oxygen, all right, in view of the severe anemia. And then she was also started on IV iron sucrose. So we started her on 200 milligrams every other day of iron sucrose for a total of 6 doses throughout the hospitalization. And at the same time, she was started on low molecular weight heparin for thrombosis prophylaxis, thromboprophylaxis, because they are PNH patients in general are pro-thrombotic. And during an acute hemolytic episode as well, there's increased risk of thrombosis. She was also given folinic acid supplementation because in patients with chronic hemolysis like PNH, they tend to develop folate deficiency as well. So we also supplemented that for her. And we covered her with IV rosapine for occult infection because we were not too sure what exactly precipitated this episode. But in view of, she was having poor appetite and all, So we suspected the possibility of an occult or atypical infection. And we did not transfuse any blood product for her during this admission. So as you can see, looking at her blood investigation trend, without any blood transfusion, her hemoglobin gradually improved over the course of 10 days from the nadir of 3.6. It has improved to 8.7. And her hemolytic parameter, her bilirubin and her LDH also improved markedly. So the LDH from more than 4,000 came down to less than 1,800. As you can see, this is just to demonstrate in July, prior to her admission to us, her ferritin level was 29, which is suggestive of absolute iron deficiency. And in October, after her admission and after she was discharged, she was followed up again. There was improvement in her ferritin after IV iron. Her haptoglobin is always low because of the ongoing, which is consistent with the ongoing hemolysis that goes on in patients with PNH. Yeah. So this paper just shows to demonstrate how common iron deficiency is in patients with PNH. It's a paper from China looking at 742 patients with PNH, and the overall prevalence of iron deficiency was almost 18%. But interestingly, in patients with classical PNH, such as our patient, iron deficiency was higher. 76% of these patients had iron deficiency. And this journal article is just to demonstrate that blood transfusions are frequently used or frequently given in patients with PNH. As you can see, more than half, 56% of patients required at least one transfusion in the year prior to be enrolled in registry. But of course, they found that those patients who had PNH associated with aplastic anemia required more blood transfusion compared to other cases of PNH, which is expected. And of course, allogenic blood transfusion is not without risk. Yeah? So there's a whole lot of complications, both acute as well as delayed transfusion reaction, the risk of transfusion-transmitted infection, iron overload with frequent blood transfusion. So there are just so many complications that can happen when you transfuse patients too frequently. So as we know, the three pillars of PBM. So in our case, basically, we are primarily focusing on the first pillar, which is optimizing hematopoiesis by giving the patient IV iron, all right, and replacing and addressing the iron deficiency, as well as folic acid supplementation as well. And of course, in order to improve patient outcomes, there are multiple things that we need to take into account. So the patient-centered decision-making is important. The patient herself expressed the desire as far as possible. If she could avoid blood transfusion, she would prefer it that way. And we managed to do that for her. And of course, managing the anemia for the patient is important as well to improve outcome. So in our case, we successfully avoided blood transfusion even with such a severe anemia of 3.6. Supportive care was given, hydration, oxygen supplementation, IV iron was given to address the underlying iron deficiency. Always treat the underlying cause. Try to look hard for any precipitating factor for the acute hemolysis and treat it. In our case, we suspected an occult infection. And of course, never forget low molecular weight heparin as well as folic acid supplementation in PNH. So in conclusion, blood transfusion is not always the answer. All right, we should optimize the use and encourage the use of IV iron and erythropoietin in this group of patients. Always treat the underlying cause. And I believe that we must always be very patient when managing anemia. So sometimes we as medical practitioners tend to, target numbers. We want to see the numbers increase rapidly. But in the case of anemia, sometimes you just have to give some time for the hemoglobin to improve. No rush. Yeah. So that's all for my presentation. Thank you very much.
Thank you, Vishnu, for wonderful presentations. I had a question. I mean, I want to ask you because the lady is on complement inhibitor, right?
Yeah.
Yeah. So do you think it is working on her?
In my opinion, it is because in between these episodes of hemolysis, she doesn't seem to require any sort of blood transfusion, and her hemoglobin is relatively quite static. Because even
What
in
is her?
February when she was admitted, she had a COVID infection at that time, and during this episode, we also treated her for an infection as well. So each episode of hemolysis appears to be precipitated by something, by an infection. But in between those episodes, the hemoglobin tends to be quite stable. Yeah. But sometimes, yeah. Sorry, Dr.
I'm
Lee.
seeing your LDH and serum hematoglobin didn't improve tremendously. That's what I would like to expect. You know, that particularly, I have a feeling she's still chronically hemolyzing.
Chronically hemolyzing, yeah.
It's the usual HB, may I know? I mean, in between without this precipitating factors.
Usually between 8 to 9.
So that is not
not optimized.
So I feel that you're right. We have to treat underlying cause, whereby she has a PNH, which is a very rare condition. You have explained it very beautifully. So I feel that she's getting not a placebo, I hope. It's a
we don't know what she's getting, right?
randomized trial, right?
Yeah.
I don't know. I just have a feeling she's not getting the right drugs. Yeah. Let's see any question from the floor as well. Oh, there's no open questions. Right. How about the rest of the moderators like Dr. Nasakigara, Prof. Ngim?
My hand is up.
I'm a surgeon, so nothing from a hematology question point of view, man. But good presentation, the nice slides.
Yeah.
My hand is up. My hand is up.
Yeah, nice presentation.
Oh,
I have no question.
Demarcus's hand is up.
Dr. Yama's hand is up.
Yes. Thank you very much for that fine presentation. I have this question. What was the level of the CD55, CD59? That is one. Two, did you have any reservation for using steroid? Three, did your peers, that is the other hematologists in your team, did they support your mode of treating without blood transfusion, or did they have any opposition, or they were fully in support of what you were doing?
I'm sorry.
Thank you.
Could you repeat the question again? I heard one about steroid.
Yes. Okay. What was the level of the CD55 and CD59? It's a measure of the severity of the disease. That is one. Two, did you have any reason to use steroid for your treatment armament? Did you have cooperation of your colleagues not to use blood? Because some centers, they will pressurize you, you must use blood. But in this case, you did not. How did you manage your colleagues?
Okay. So the diagnosis of PNH is actually made by flow cytometry. So basically, we look at the proportion of the cells that lack the GPI anchor. So usually we look at how large the PNH clone is to determine the severity. But there is not really any role of steroid for PNH per se, not that I know of, because usually based on the pathophysiology, so it's complement mediated. So basically what we need to do is we need to sort of we need to use something that can sort of block the complement activation. So that is why complement inhibitors come into play. So for example, we have eculizumab, which is a C5 inhibitor, and there are now trials involving newer complement inhibitors as well. So steroids don't really, I wouldn't think steroid would work, because steroid would work if it is an autoimmune condition, if there are autoantibodies. But in this case, it is a mutation in the gene itself that results in the deficiency. So I do not think steroid would work for this group of patients.
There's another third question regarding how you handle those, your colleagues who advocates blood transfusion. Because most of the people like
that is not an easy task. Not an easy task, because as you can see, even in June, when she was entered in April, she was admitted, she was transfused with 2 pints of red cells. So I think it is all about, education and raising awareness through patient blood management conferences and workshops. Sometimes these cases like this, we should highlight these sort of cases to our colleagues to show how, without blood transfusion, we can still achieve good outcome in our patients. So it's not easy, even among the hematology fraternity as well sometimes. So there's a lot of education that needs to be done.
I just got to know Dr. Inyama is actually a consultant hematologist. Am I correct? Dr. Inyama, are you there?
Correct. Yes. Yes.
Yeah. What you know about the CD55 and CD59, huh? So I want to explain a bit more. So we normally diagnose it using the flare in our sensor, which is the fluorescent aerolysin, which is on the white cells as well as on the monocytes. Whereas for the CD55 and 59 on the red cells, we don't do it. Whereas the other sensor is doing it, but they need a fresh samples. I think you're right. We could actually see how the severity is, but I think it wouldn't be able to kind of like change the management much, because we have a lot of other hemolytic markers as well. Well, what do you think, Dr. Inyama? Is it being done in your center? I just want to know.
Yes, of course. If you get some clones with a very low levels of CD55, you know what to expect in the clinical expression of the disease in this patient. There are some that the level of deficiency is not so severe, and you can manage even as an outpatient.
Right. I think you're talking
this group of patients, and they will do inflammation going on in this cohort of patients, especially depending on the severity of the disease. So anything that you can use apart from the targeted therapy like eculizumab can also help in ameliorating the disease and letting the person stay less. Number of hospital stay is reduced in this cohort of patients, in some patients.
Right. Thank you, Dr. Inyama, for the very enlightening opinion. Yeah, Vishnu, we learned something. Yeah. So I just would like to ask, is the other two presenters around? Like Dr. Oji Ludu, as well as the Oyewa.
Dr. Oyewa.
Are you there? Because we have 2 more abstracts, supposed. Oh, yes, you're on. Prof. Nim, over to you.
Are you? Okay, Dr. Oyewa, are you on? Oyewa, can you hear us? Our audio is still not coming up. Dr. Yewo, are you there? I don't know what's happening. Can anyone hear her, please?
Your audio is not on. I don't think we can hear you.
Dr. Soro, are you there?
Maybe when he,
I think she can hear us, but she can't reciprocate back.
maybe when she shared the screen, she did not click the bottom left that should share
Please,
the.
Dr. Soro, can someone reach her to tell her what to do?
Yeah, I tried to send her a message, but she didn't respond. I sent with Zoom.
You may call
Maybe
her.
Maybe ask her to
But
dial in.
I think the problem is that she's on the road. So it's difficult to make a presentation. But the other doctor, I saw him here. I think gone off. He could perhaps say something.
Maybe Dr. Mandy, we move on to the other presenters and wait for Dr. Yewo's technical issue to be resolved.
Dr. Ife Kandu, are you able to turn on? Can you say something?
Yeah.
It looks like for Dr. Ife Kandu is completely is not able to do it. He's not able to study. The failure of technology there. So,
can you hear me? Can you hear me?
Yes, we can hear you now.
Right.
Yeah.
Okay,
So
let me have a good look.
Yes, carry on, Dr. Yewo.
So Professor Ngemi, you want to introduce her topic and herself?
Again, let me do that again. She'll be speaking on the management of severe anemia in metastatic prostate cancer, a case study on the use of erythropoietin, ion therapy, and adjunctive care. She is a consultant urologist in General Hospital, Lagos. Dr. Yewo, you have the floor, please.
Good afternoon, everyone. Good evening. My presentation is as written on the screen, and I've been introduced. We're using this outline. Prostate cancer is the commonest malignancy in men after skin cancer, and for our local environment here, it's quite common. And unfortunately, many of our patients come with complications and advanced disease. However, in metastatic prostate cancer, the sources of anemia are multiple folds. Could also be from the bleeding prostate, nutritional anemia from anorexia, or urinary tract infections as a result of bladder-led obstruction from the enlarged prostate, or chronic kidney disease from neglected or unrecognized obstructive uropathy, which could result from the pathologic prostate growing and occluding the ureteric orifice on one side, which may be the beta kidney, or obstructing the bladder outlets, thus obstructing both ureteric orifices and causing back pressure and chronic kidney insults that result in chronic kidney failure. Could also come down with bone marrow metastasis, which is not very common. And then, of course, it is common, though we're seeing more of that around these days, is from hematochezia, from rectal infiltration of tumor. Now, in this subset of patients who develop anemia with their disease, a multidisciplinary and multifocal approach to resuscitate these patients, correct the anemia, yields very good results. I'm here to talk about the care of a 65-year-old male Jehovah's Witness who was referred to my facility July 2023. He had significant bothersome lower urinary tract symptoms. He was already on a urethral catheter and had recurrent episodes of bacteria that were self-limiting. He was referred with a Paxil volume of 14% at that time. And in my care, he's been co-managed with a nephrologist, the laboratory scientist, radiologist, and the nurses. Now, thorough clinical history helped us to identify the complications he had suffered, likely from the disease evaluation and progression. And then we made a number of radiological investigations, ultrasound, X-rays, multiple of that, and then a spectrum of laboratory investigation, particularly the hemogram, the electrolyte kidney, electrolyte urea and creatinine evaluations, and then these were done periodically. I also applied the use of subcutaneous erythropoietin, intravenous iron, had to put in a urinary diversion for him, and eventually needed hemodialysis in an environment of hope. Because for him, everything seemed to be, downhill and moribund at presentation. Clinically, from the history, he'd had progressive weight loss, had progressive facial and pedal swelling. He also had pain in his left humerus, with swelling of that left upper limb, which suggestive of bone metastasis, had recurrent nausea, vomiting, didn't allow him to feed. He, however, had no medical comorbidities. My diagnosis at his presentation was that of a metastatic prostate cancer, severe anemia, and renal failure from obstructive uropathy. Now, at this time, he was unfit for us to talk about performing a prostate biopsy to get pathological diagnosis. And as urologist, this assessment was made and discussed with the patient and his relatives. Resuscitation swung in, he was put on IV fluids, the electrolyte derangement were corrected, supplemental oxygen, DBT prophylaxis were all commenced. So requested for a number of investigations that outlined, and he was put on these fluids and analgesia for the pain, oxygen supplementation, and had nutritional support. The ultrasound revealed bilateral grade 3 hydronephrosis with cortical atrophy. That I was speaking, had 120 gram prostate, all in keeping with obstructive uropathy. And the lumbosacral X-ray, not really any classic features of bone metastasis. Peripheral blood film revealed hypochromia, pencil cell fragmented cells, and anisopoikilocytes. White cell count revealed features that suggested infection, and high white platelets were adequate on film. At the trend of the hemogram, with the use of urinary diversion, which we achieved using ultrasound-guided, nephrostomy tubes, which were inserted to relieve the obstruction to the kidney from the malignant ureteric obstruction from the prostate cancer. The hemogram he did revealed a trend. If we look at the Paxil volume between July and October, when he was seen at the outpatient clinic, he had a progressive rise, though it dropped sometime in September when he went home and left the presence of his caregiver who was there with him initially. He had a urinary tract infection and the hemogram dropped. That was promptly recognized and treated. And as of now, we're at a Paxil volume of 22 from 14%. The renal function also progressively increased. The EGFR at presentation was 7. Okay, and we had this progressive increase up until 16.2 that we have now. And the urea and creatinine have also progressively normalized. PSA trend with the medical management of the malignancy that was suspected and clinically diagnosed revealed a progressive reduction from 1,200 and 600 grams per mil up until 89, which is the last we've done. So IV iron, at the time it was checked during his care, was elevated, and so the IV iron was discontinued, and it's been on oral iron and substitute erythropoietin, additional to high protein diets and liberal food intakes, fruits, vegetables. We, however, commenced bicalutamide for presentation, which was is one of the means of monotherapy in treating advanced prostate cancer. And when the renal function was improved, commencing on subcutaneous sertraline, which is to take 3 monthly. It's not due for the second dose, but the PSA seems to have dropped significantly to our nadir, which we will refer to now as the 89 nanogram per ml. Now, clinical presentations such as this could be turbulent. There's a lot of anxiety in the air for the patient who is, quite acutely ill. The relations who are seeing him or him deteriorate, and this the proper compassion and empathy to give hope for whatever is available and accessible to us with regard to human resources, and reaching out for all the other specialties that could assist to make the patient's time with us comfortable. So a prompt identification of all any abnormalities from the laboratory work, from clinical examination, neurological deficits, pain assessment, breathing, assessment of even the mental state of the patient are all important and need to be synchronously treated. For him now, he had severe anemia, azotemia, he had bone pains, he had malaria, he had anorexia. So repeated counseling about progress of the reports, the investigations, trend, how he was making slow but steady progress, helped, improve his own outlook to the disease and helps achieve the goals, which was to keep him alive, as we make him fit enough to access perhaps a formal diagnosis and subsequent treatment. In conclusion, severe anemia as a complication of metastatic prostate cancer have been managed with good outcomes, with multimodal care and multidisciplinary care supplied. So in addition to the use of iron and erythropoietin, I had to divert urine, I had to give oxygen supplementation, I had to ensure he was feeding well. We had to repeatedly talk in an encouraging way to keep his hope alive. That was how things were, especially when he needed to go, have dialysis. It was a challenge getting a nephrologist who would dialyze him, with that degree of anemia. So the judicious use of intravenous iron and erythropoietin, nutritional support, recognition promptly, I say again, of preventable and correctable complications, consistent emotional support, can help improve our patient outcomes. Thank you very much for listening. I apologize for technical hitches. Thank you.
Yes, thank you, Dr. Dutola Oyewo, for that beautiful presentation. I just want to ask, how was the erythropoietin given? How much and how often was it being given to be able to achieve this level of improvement in the hematocrit over this period of time?
Yes, he had 4,000 international units twice weekly.
Okay. Yes, all right, thank you. There's a question on the chat box. It says that the rate of increase of the PCV is a bit slower than expected with the erythropoietin, and is wondering if the kidneys could be failing and if it's being affected by dialysis.
Yes, he presented with
Did you hear?
Yes, I heard, sir. Thank you, sir. He presented with an
Hello.
I can hear you, sir.
Dr. Yewo.
I can hear you, Prof, sir. Can you hear me?
Yeah, we can. Oh, yeah, we can. Please go ahead. We can hear you.
Right. So he presented initially to us with an estimated glomerular filtration rate of 7. That's end-stage renal failure. Okay, and with the urinary diversion and the dialysis, we're at 16 now. So I dare say I'm happy with what we have. I wasn't expecting that much progress. Where I trained.
Did you hear me, Dr. Yewo?
I can hear. I heard you already. I don't know if you can hear me.
Okay, carry on if you heard me.
Yes, sir. I said he presented with an estimated glomerular filtration rate of 7, which is end-stage renal failure. Okay, and with the care he has received, we progressively increased conjunction with dialysis to 16. So he's done well considering the circumstances, and I can only hope it continues to improve. I'm expecting to see him in 2 weeks' time, where I'll run another set of labs to see where we are.
Okay, thank you very much. The other panelists, do you have any comments or questions for her? No other question on the panel, on the chat box. Dr. Mandy?
Yeah, I saw another questions from someone from Oliver
Okay.
was asking
Okay,
what
okay.
was the
PCV,
CB when
the first dialysis was done. Yeah. Dr. Yewo?
I think you're muted.
Dr. Yewo, did you hear the question?
18%. 18%.
It's 10%.
18%. Okay, thank
18.
you.
18.
18.
Yes, sir.
Any questions from the panelists, please? For her?
Nothing from my end, Ewo. Good presentation.
Yeah, nothing from me as well. I think you
Thank you very much.
Okay, thank you, Dr. Oyewo. Just one last question. When do you expect to do the biopsy?
Well, that will depend on his creatinine, his kidney function test, because we will need his kidneys to perfuse his body if he develops post-biopsy sepsis. So he's supposed to see me in 2 weeks, where we run another set of labs and the hemogram. So I was hoping we could get to 25, before I do that, so that he will have some reserve if he develops post-biopsy infectious complications. So right now we've started him on glucerolin, in addition to the bicalutamide tablets as a treatment for the suspected cancer. So that's the plan.
It's okay. Thank you very much for the presentation. Dr. Mandy, over to you.
Oh, thank you. May I ask, is Dr. Ojiludus there?
Hasn't
Yes.
been responding. So I think he has, he has a problem with his microphone as well as his video. Or if I am wrong, please say something, Dr. He's not saying anything. Yeah, he's not saying anything. I think he has some challenges. Maybe he has to prepare for the next meeting.
Oh, we probably have to let him speak next round. Right. Shall I pass it back to you, Nathaniel? Or I think
yeah, that's nice of you, but I'll still pass it back to you. I think it's either you or Prabhu that was to close the meeting. I think Prabhu was to say something.
Yeah,
also.
I think yeah.
Well, I think thank you all for joining the conference, and I think it's a good presentation from multi-specialities. It's nice to see representation from across continents to joining this cause. And also this is a prelude for tomorrow. So I'm just going to show the program for tomorrow who want to join in. So I don't know if you can see this. So tomorrow is all about medical legal ethics and medical legal issues. Is a very important part of medicine practice, especially bloodless medicine practice. So I encourage all the delegates to attend tomorrow for this interesting talk and discussion. Please feel free to keep communicating on the chat group for any questions or suggestions. And I think Nathaniel will take it forward for the next 2 days and the next meeting across. So thank you. Good night. I think Mandy, you're at 11:30 at night in Malaysia. So maybe first good night to you guys, and then hopefully for the rest of the continents.
Yeah, that's good. I'm still awake.
Okay. Thank you all and have a good night.
Yeah, thank you. Good night.
Thank you, everybody.
Good night.